Ladies and gentlemen, we're going to get started here shortly. If we have time permitting, those that want to speak, there's a sign-up sheet on the front left-hand side, my left-hand side, on the first row here. If you're going to speak at the end of and address the committee, please make it short at that time. Is Dr. Sumner? There she is. Ladies and gentlemen, this phenomenal facility here was made available today, and I really want to thank Dr. Sumner for giving us the opportunity. We're coming here for the House Study Committee on Pharmacy Benefit Managers, Consumer Access to Prescription Medication, and this facility, thank goodness for this, and of course this amazing school as well. I'd like to recognize Dr. Sumner for her hospitality. Would you give her a hand?
Four-year campus in Columbus with two-year campuses in Carrollton and Valdosta that are growing and great campuses. If you make that arc, you will see that everything in that cubbyhole that we cover has very poor health status, and we're committed to making it better. So thank you again.
Thank you, Dr. Sumner. And again, appreciate so much your hospitality. I want to go through the members of the committee first, and we'll start it to my left if I can. If you'll press your button and introduce yourself. Members.
Good morning, Mr. Chairman. I'm Representative Butch Parrish, represent District 158. I live down in Swainsboro, Emanuel County. I represent Emanuel and Troutland and Candler and a portion of Bullock County. I chair the Rules Committee in the House and also the Special Committee on Health Care. Glad to be with you today. Thank you.
Well, good morning. My name is Lee Hawkins. I'm from Gainesville, Georgia. Well, actually north of Gainesville, North Hall and part of Lumpkin. I've been around doing this for 20 years, not as long as Butch or Ron, but been around for a while. I chair the Health Committee and obviously very interested in all these issues and really appreciate you coming today and us having the opportunity to hear your opinions. And I want to thank the chairman here for arranging this for us today. Thank you.
Good morning. I'm Debbie Buckner, and I represent House District 137, which is rural Talbot County, where I live, Meriwether County, Troup County, the rural part of Muskogee County, and Columbus. And I am a public health educator by profession, but my claim to fame is the mother of two Mercer bears.
Good morning. I'm Matt Hatchett, District 155, represent Lawrence and Johnson counties. I have two Mercer Bear graduates also and happen to be able to call where you are today my other job, my real job. So welcome to Mercer. And I just was thinking about it, Ron, I'm the shortest serving representative up here, and I've been there 16 years. So I'm the rookie. How about that?
It again is a pleasure to be here today. My name's Ron Stevens. I represent Savannah, Chatham County, Bryan County. Bryan being the fastest growing county in the state. Again, 29 years, class of 78 from Mercer, and I'm a Mercer Bear. My daughter is a Mercer Bear. It's a real honor to be here and in this amazing facility. I want to recognize as our first speaker today, no stranger to us, who served in the Georgia House of Representatives and also served in the Georgia Senate and as a 10-year veteran in United States Congress, and also a very good friend of healthcare and a good friend of mine. It's my honor to introduce Congressman Buddy Carter.
So thank y'all very much. Is this working?
Press the button, I believe.
Press the button. Yeah, that's what we do in Washington. We press the button. Well, thank y'all very much for having me here today. It is an honor to be here, and thank the study committee for the work that they're doing. This is extremely important. Prescription drug prices, healthcare in the state of Georgia is something that Chairman Stevens, that Chairman Parrish, and everyone on this panel have worked on for many, many years. Dr. Sumner, thank you for your work here, and we've worked together for many years, and it's been an honor. We are very fortunate in the state of Georgia to have you and the work that you do. Before I begin, I want to recognize two of my staff members who are here. First of all, Matthew Worth, who is a Georgia product from Cumming, Georgia, and went to Georgia College and is my district director down in this 1st Congressional District. And also Connor Mills. Connor is from Beaufort. Connor is our legislative director up in Washington, D.C. He also doubles as my bodyguard. He played football at Princeton, so he does a good job as that as well. But I thank both of them. I'll get right into it. I'm going to kind of do my Donald Trump impersonation today, and that is I'm going to try to follow the script, but I will ad-lib, and trust me, you'll know when I go off script, and I'm going to do that today. First of all, again, Chairman and members of the committee, thank you for the opportunity to be with y'all. As a pharmacist who spent more than 40 years behind the counter, I started when I was 10, by the way, so that explains that. But I spent 40 years behind the counter. I've watched the prescription drug marketplace become more concentrated, more vertically integrated, and more difficult for patients, for employers, for pharmacies, and even sophisticated purchasers to understand. For me, the central question is simple. Can we follow the claim? Can we follow the dollar and determine whether the savings somebody says were negotiated were actually realized by the patient or the purchaser? You know, I'm going to ad-lib now and tell you that when I started practicing pharmacy in 1980, PBMs were nothing more than processors. They just processed claims. And Representative Stevens and I worked together for many years in the same pharmacy at the same location. And I can tell you, that's all they did. They just processed claims. But as they evolved over the years, we see what has happened with the PBMs. They have become more than just claim processors. And I like to explain it this way. Really the way this evolved was that hospitals really started out with formularies. And in order to get that formulary, you had a drug on the formulary, and all of a sudden, the insurance companies, the PBMs, realized that, hey, we can have an impact here because if we can get our drug on that formulary, and then we can actually negotiate a price. And when the insurance companies would cover something, they would go to the manufacturers and they would actually say, hey, if you want to have your drug on our formulary, yes, we have a P&T committee. Yes, we're going to look at the efficacy and make sure that it is a drug that works. I'm not denying that. But at the same time, you cannot deny the fact that the price negotiation factored into that as well. And that's something that we need to be aware of. When I entered Congress, and it was 12 years ago, not 10 years ago, but when I entered Congress 12 years ago, the first thing I did when I got there was go to the FTC, the Federal Trade Commission, and ask them to look at the vertical integration that exists within the drug pricing chain, where the insurance company owns the PBM, the pharmacy benefit manager, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. You know who's the leading employer of physicians in America today? United Healthcare. United Healthcare employs 9% of all physicians. Now, there's nothing wrong with working for United Healthcare, but an insurance company is the leading employer of physicians in America. That should tell us something. I asked the FTC to look at this, and finally, 3 years ago, they started what they refer to as a 6B study to see the impact of what PBMs are having on independent retail pharmacies. That study has been going on, as I say, for about 3 years now. They've come out with a number of interim reports, and they're going to come out with a final report, hopefully in the future. I believe you're going to be hearing from the FTC via Zoom here later today, and I appreciate their work, and I appreciate them doing that because that's very important. This study is very important. Already, they have gone from just trying to understand the problem to really enforcement, because they've actually, and they told me this from the beginning, whenever they would find something wrong, they weren't going to wait until the end of the report. They were going to go ahead and address it. And they have addressed a number of things and made some good progress in making sure that we have what we all want, and that is transparency. So first, the FTC and their work on the PBMs. For years, pharmacists, employers, patients, and states have raised concerns about formulary incentives, pharmacy reimbursement, steering rebates, and the growing power of the largest PBMs. The FTC has now moved from studying those issues to enforcement. Its actions involving Express Scripts, Optum Rx, and Caremark are important not simply because of the settlements themselves, but because of the business practices they address. List price link compensation, rebate guarantees, spread pricing, point-of-sale rebates, pharmacy reimbursement, and the information available to plan sponsors. That goes directly to what I was talking about earlier, the vertical integration that exists. Whenever you can have, what we experience here is patient steering, where the insurance companies are actually steering the patients to their own pharmacies, whether it be a mail order pharmacy. Now, they'll deny this, but I have to share a story with you. I own my own business for over 32 years. And I worked one day and I came home that night and the phone rang and I picked it up. And sure enough, it was the insurance company and said, "May I speak with Miss Carter?" And I said, "Well, she's not available right now, but can I help you?" They said, "Yes. She had a prescription filled today at a local pharmacy, and we just want to let her know that if she gets that prescription through mail order, we could give her a lower copay." That's a true story. This was when I was practicing. I filled it at my pharmacy, and they wanted me to send it to them. That's what's known as patient steering. And that's something that yes, it has been curtailed to a large extent, but it still exists, and it's something we have to be aware of. And we have to understand the PBMs. They are what is referred to as the middlemen. They are the ones who really bring no value to the healthcare system, although they will argue they do, but they really don't bring value to the healthcare system, but they cause the prices to go up. Why do they do that? Because when they negotiate the price, first of all, we can't see it. The transparency is the most important thing. We can't see it, but what they do is they don't pass it on. I'm fine with them getting discounts from the manufacturers. In fact, I think that's a good thing. But we need to see that it is transferred and it is passed on to the consumer at the point of sale or either at some point. That's what's so vitally important. Now, the vertical integration is not automatically unlawful. You know, I say all the time, who am I voting for president? I'm voting for Teddy Roosevelt. We need him back. We need him to come back and to bust up the monopolies, because that's essentially what this is. But it's a standard which we have to make sure that we address this, and we have addressed this. Now let's talk about the IRA, the negotiated price versus the realized savings. Second, we should apply that same discipline to the Biden-Harris Inflation Reduction Act. All of you will remember the Inflation Reduction Act that was implemented during the Biden-Harris administration. And what that did was it said that we're going to take 10 drugs every year, 10 of the most expensive drugs, and we're going to get them to bid on those drugs for a price. This current administration has actually proposed extending that and expanding that to include 25 drugs now. So this is something that is important. And look, I'm not up here to take up for the drug manufacturers. The drug manufacturers have responsibility here as well. They need to do a better job of drug pricing. However, I will tell you this. I practiced pharmacy, as I said, for over 40 years. I have seen nothing short of miracles as a result of research and development. I can remember when you were diagnosed, and Dr. Sumner, you remember this, when you were diagnosed with hepatitis C, you were going to die. That's all there was to it. Now we can cure it with a pill. I mean, how phenomenal is that when you stop and think about it? When I started practicing, you were going to die if you were diagnosed with hepatitis C. Now we can cure it with a pill. That's phenomenal. That's why we need research and development. So I'm always cautious in doing anything that's going to deter research and development. However, again, I will reiterate that the drug manufacturers need to do a better job with their pricing. Some of these prices are simply out of control, and they need to be held responsible for that. And fortunately, the administration has done that. They've done that through a number of different programs, not the least of which is the Most Favored Nations. Now, all of you will know Most Favored Nations, and those of you who are pharmacists know that we've had this in the Medicaid program for many, many years. It wasn't necessarily enforced, but it's been in place for many years. And Most Favored Nations is simply where you say, well, if you sign a contract with a provider, with an insurance company at a certain price, the lowest price that you accept, that's what you've got to give to Georgia State Medicaid. That's what Most Favored Nations is. And what the administration did is they came in and they said, look, we're getting all these complaints from other countries that have lower drug prices, and why should we be paying the higher drug prices over here? So the Most Favored Nations that the administration has negotiated with 17 different drug manufacturers, what they're saying is that the lowest price that you charge anywhere in the world, that's what you're going to have to pay. That's what you're going to have to charge here in America as well. Now, you get into a lot of intricacies here. There will be an argument that some governments, they supplement those. The government is actually supplementing the pricing there, and that's why the cost is lower. Also, the availability of drugs is something you need to pay close attention to, because not all drugs are available in foreign countries like they are here in America. So that's something else that factors into it. But it is something that I applaud the administration for what they're doing, because we do need to address the fact that we're doing the research and development here in America, and that we're doing all of the studies, and the FDA is making sure that these drugs are safe and effective, and yet other countries are benefiting from that, and we're paying the price there. So I applaud the administration for what they're doing. But what we see is that the PBM compensation still rises, and it's still rising even though the list price may come down. Now let's talk about, let me see where I'm at here. Now let's talk about what's going on with, with the Trump administration. You've heard about the Trump RX program. That's simply a discount program that the administration has negotiated with a lot of the drug companies. And the way this works is that they've come with the drug companies, they've negotiated a price down. You can take advantage of that price. A consumer can take advantage of that price. You will get a coupon, a discount coupon that you can take to your pharmacy, or you can mail it in, and you'll get that discount. The problem with this is that it's not going to apply to your insurance. It won't go toward your deductible. So that's something to keep in mind. That's something very important, because if you're not getting it for your deductible, your out-of-pocket cost, it's not going to be added to that. It's cash only. It is a significant savings, and it is helping people. It's helping a number of people, and I applaud, again, the administration for doing that. Now let's talk about some of the things that we are working on in Congress right now. First of all, at the first of this year in the Consolidated Appropriations Act of 2026, we were able to pass the most significant PBM reform that we've ever had in this country. I was proud to be the lead sponsor of this. It really included 3 different things. And what it did was, first of all, it delinks the price of the drug from a percentage of the drug to just a simple flat fee. Some of these PBMs were marking up these drugs thousands of percents. Well, we ended that, and we said you could only do it for just a markup. That is significant, and that is very good. The second thing it did is that it called for more transparency. It called for more transparency so that plan sponsors and that so that employers can see the discounts that the PBMs are getting. As they see these discounts, they're going to demand that those discounts be shared either with the employer, the plan sponsor, or with the consumer. And that's very important. The third thing it did, and I was very proud of this, is that it called on CMS to review some of these contracts between pharmacies and the PBMs or the insurance companies and make sure they were reasonable and relevant. Now, CMS is pushing back a little bit on this, so we're probably going to have to massage this some, but they're pushing back on it some because they say we really don't have that authority to do that. But this is important. Look, folks, I've been remiss in that I didn't bring this up at the very first. This is a bipartisan issue. I don't know about Representative Stevens or Parrish or anyone else. I never went to the counter and asked someone if they were Republican or Democrat. I never did that. All I knew is that their prescription drug prices were high. This issue of prescription drug pricing and of the impact that PBMs are having on it, this is a bipartisan issue. At the end of the day, whether you're Republican, whether you're Democrat, or whether you're an independent, we all want the same thing. We want accessible, affordable, quality health care. That's what Georgians want. Accessible, affordable, quality health care. That's what we all want. Now, let's talk about accessibility, because when we talk about accessibility, pharmacists are the most accessible healthcare professionals in America. 88% of all Americans live within 5 miles of a pharmacy. Now, as these independent retail pharmacies continue to close because of the pressure being put on them by PBMs and by insurance companies, that impacts accessibility to healthcare in Georgia. That's what we've got to be aware of. This is significant, what is happening here. That's why we're so serious about it in Congress. That's why we're trying to do something about this. And we're continuing to work toward that. And that's very important. So what are we working on now? One thing that we're working on is what's called the Main Street Pharmacy Access Act. It's also being called ECAPS. It's also been referred to as provider status, so that pharmacists can get reimbursed for the consultation that they're doing. Yes, I am a pharmacist by profession, and I'm very proud of our profession and what we did, particularly during the pandemic. I was so proud of our profession, the way we stepped up with vaccinations, with consulting. That was so very important for people during the time that all of us didn't know what was really know what was going on. So that was very important. At that time, pharmacists were reimbursed for those services. We need to continue that. We need to continue that, and that's what we're working on right now. This legislation that I'm referring to is actually in the Ways and Means Committee. Keep in mind, the Ways and Means Committee in Congress is the Tax Committee. It's also got jurisdiction in the Energy and Commerce Committee that I serve on, and that we will have also an opportunity to address that legislation. So this is going to be very important. This is important. It's important, as I say, to make sure that rural healthcare in particular, that pharmacies remain viable. Now, I want to touch real quickly, and I'm sorry if I'm going too long. I want to touch real quickly on a couple of things. First of all, as I mentioned earlier, you're going to hear from the FTC later, and I appreciate what they're doing, and I appreciate them taking time out to let you know what they've done, because they've actually negotiated with some of the insurance companies and come up with some things that are going to help and immediately, and that's very good. But I would be remiss if I didn't have the opportunity to address the 340B program. The 340B program is a vital program, particularly for rural healthcare, particularly for the FQHCs, the Federally Qualified Healthcare Centers. We understand that. Now, keep in mind one thing that has happened here. First of all, the 340B program has proliferated into something that was never intended to be. Hospitals and healthcare systems are using this program, and they've become dependent on this program. And I get that, I understand that. But the problem with the 340B process is this: as those hospitals, I'm not denying that they're losing money in certain areas. I know they are. But if they're using the 340B profits to mask those areas, I can't help them. If I can't see it, I can't help them address that. Maybe there's something I can do to help them in that areas that they're using this 340B profits in order to mask those areas. I get it. But at the same time, we've got to address it. Why has this become a problem? Because a lot of the 340B sites that it was intended for, like the FQHCs and like the rural hospitals, all of a sudden are suffering. One of the reasons that they're suffering is because the spread, the amount that you get as a result of the 340B is not as much as it used to be. In fact, in an Energy and Commerce Committee hearing just a couple of weeks ago, we heard that there are some FQHCs in West Virginia that are closing down because the 340B program is not as profitable as it used to be. As we negotiate these drug prices and the profitability comes down, then that's going to impact that program. That's when the list price comes down, that impacts the 340B program. That's one thing we've got to have to keep in mind. But the 340B program has proliferated into something that it was never intended to be. I'm not anti-340B. In fact, I think it's a great program, a needed program for the FQHCs, for the rural hospitals. But it has proliferated, as I say, into something that was never intended to be. I would submit to you that a number of these healthcare centers are buying up physician practices, particularly oncology practices, for no other reason but to get the pricing of the 340B. And that's leading to more consolidation in healthcare. Now, consolidation in healthcare is something that really does bother me. We were in a Energy and Commerce meeting. It wasn't a hearing, it was a meeting of our committee members, and we had the CBO, the Congressional Budget Office. They are the economists who tell us how much a piece of legislation is going to save or how much it's going to cost. We have to, they're very rarely right, but we have to listen to them and we have to go by what they say. Sorry, they're not right. And they've gotten it wrong too many times. But I will tell you this. I asked them, I said, give me one example of where consolidation in healthcare has saved money. They could not give me one example. This was the administrator, the CBO administrator, and 20 of his staff members. They could not give me one example. So I've gone from talking about just drug pricing to healthcare in general. Look, I'm not saying that the quality that these healthcare systems are offering of healthcare is bad. It's not. It's good. And we appreciate them. We appreciate them very much. But I would submit to you that we've got to have more competition in healthcare. That's what's going to bring the prices down. And I'll try to wrap up now just by saying, when you put all this together, the FTC investigations, the vertical integration, the PBM rebates, the spread pricing. I didn't mention spread pricing. And that was one thing in the Consolidated Appropriations Act of 2026 that I mentioned earlier. We had 3 things in it. That was the 4th thing that we were hoping to get in. I mentioned the CBO. Get this now. This really will tickle you. It tickled me. Originally, on the spread pricing, that's where an insurance company will pay one price for a drug and then charge another price for a drug. They may pay $5 for it, but charge $10 for it. That's what we refer to as spread pricing. Whenever the CBO first started, we asked them to look at spread pricing in this legislation that I had as part of this, and they said, oh, it's going to save over $1 billion. Whenever we got to the floor with the bill, they came back and said, oh, we made a mistake. It's not going to save over $1 billion. It's going to cost over $6 billion. How do you go from saving $1 billion to costing over $6 billion? I just don't get it. But that's what we have to go with right now. We're asking them to review that right now, and that is something they're looking at. But spread pricing is something that's a problem also. We've also talked about the Trump administration, the manufacturer agreements, Main Street pharmacy access, healthcare transparency, and 340B. The same test applies to these as it did with the PBMs. What was the acquisition price? What is the real price? That's what we're looking for here. What did the plan pay for it? That's what we need to know. That's why we have to have transparency. What did the pharmacy receive in payment? What did the patient pay? What rebates, what spreads, what fees, other remuneration were generated? Who received them? And can the independent auditor reconcile those numbers back to the claim? Georgia doesn't have to wait on Washington just to get some of these things done. In fact, I will tell you, 2 states thus far, Arkansas and Tennessee, have passed laws that says that PBMs cannot be owned by insurance companies. That's already been said. That that a PBM cannot own a pharmacy. I misspoke there. The law that they passed is that a PBM cannot own a pharmacy because of patient steering, because of the incentives, that type of thing. I applaud them for that. There are other states who are looking at this, including New York. New York's looking at it as well. This is legislation that needs to be done. But at the federal level, the message I bring to you today is that we're finally making progress. We are making progress, and I want to, again, thank the Trump administration for what they've done. They've made a lot of good moves, a lot of things. Yes, we do have to be careful that we don't discourage research and development, but at the same time, we've got to make prescription drug prices more affordable. I've seen this over the years. I've seen how it has evolved. And that's why I applaud this study committee and what you're doing and addressing what is a simple solution. And that is that we've got to have more transparency. We've got to hold these PBMs, these insurance companies, more accountable. Mr. Chairman, again, thank you for having me here today. I apologize if I spoke too long, but I get kind of passionate about this. I've spent most of my professional career on this, as you have, and many of you have, and it is extremely important.
Congressman, thank you so much for kicking us off on a really good note of education. Members, have you got a question? If not, I appreciate you very much.
Debbie Buckner doesn't have a question for me. She always had a question when I was in the house.
She was taking copious notes.
Now's time.
Thank y'all very much.
Thank you, Congressman. Do we have the FTC? They were supposed to be up next, and we do have them online, the Federal Trade Commission. We're going to get a report from these guys.
Good morning, Mr. Chairman, members. Can you hear me all right?
Yes, Susie, thank you.
Well, it's great to be here. Thank you for the invitation to speak about the FTC's work on pharmacy benefit managers, or PBMs. My name is Susie Jing in the FTC's Office of Policy Planning, and today I'll provide a brief overview of our Section 6B study, and then I'll cover the key findings of our 2 study reports. So as a quick disclaimer, the views I express here are my own and don't necessarily reflect the views of the FTC or an individual commissioner. As Representative Carter mentioned earlier, the Commission issued orders in June of 2022 to examine PBM business practices and their impacts on access to affordable prescription medicines. These orders were issued to the 6 largest PBMs, including to what I'll refer to as the Big 3, that is CVS Caremark, Express Scripts, and Optum Rx, as well as the smaller 3 of the 6, that is Humana, Prime Therapeutics, and MedImpact. In 2023, we issued another 3 orders to companies that were spun off by the Big 3 PBMs to negotiate commercial rebates. So in our first report, we described how increasing vertical integration and concentration have enabled the Big 3 PBMs to manage nearly 80% of all prescriptions filled in the U.S. The top 6 PBMs accounted for 94% of all prescription drug claims. So these largest PBMs are part of corporate conglomerates that are integrated with large health insurers and retail specialty and mail order pharmacies, among other entities. In addition, our first report reviewed numerous PBM contracts with pharmacies, and we had public commenters expressing concern that PBMs may be able to hold substantial influence, especially over small independent pharmacies, by imposing contractual terms that may impact pharmacies' ability to stay in business and serve their communities. We found that the PBMs themselves refer to these contracts as unilateral or passive contracts. And these contracts are really more like notifications, and they set terms and take effect automatically. Terms often change reimbursement rates, network participation, and covered drug lists. Moreover, reimbursement methodologies to pharmacies are complex and opaque. Payment terms often rely on shifting confidential inputs that PBMs can change at will. This makes cash flow unpredictable for independent pharmacies, and we found that between 2013 and 2022, about 10% of independent rural pharmacies closed. Now turning to our second report, the FTC expanded a number of empirical analyses we found in the first report. Specifically, we reviewed data from the big three PBMs for 51 specialty drugs. This sample makes up 91% of specialty generic dispensing by the big three PBMs during our study time period. These are off-patent drugs, and they're used to treat serious diseases and conditions like cancer, HIV, and patients receiving transplants. The second report looked at reimbursement dollars for individual drugs versus their estimated acquisition costs. We found that over the 2020 to 2022 period, specialty generic drugs were often marked up by 100% and sometimes over 1,000%. Now, for almost all of these drugs, PBMs paid their own affiliated pharmacies more than the unaffiliated pharmacies. The payment differences were generally greater for commercial drug claims as compared to Medicare Part D claims, where we believe federal oversight limits steering. We found that PBMs were able to direct the most profitable, highly marked up drugs to their own pharmacies. And looking closer, we found that a relatively small number of specialty generic drugs generated a disproportionate share of the PBM parent organization's operating income. So the top 10 drugs generated $6.2 billion, or 85% of the total. This is significant because it represented over 10% of operating income to the parent healthcare conglomerate's business segments. Spending on specialty generic drugs has grown rapidly for both plan sponsors and patients. Between 2017 and 2021, spending increased at compound annual rates of over 20% for commercial claims and around 14 to 15% for Medicare. In 2021, plan sponsors paid $4.8 billion for specialty generic drugs, and patient cost sharing totaled $297 million. Again, we appreciate your interest in our PBM work. Our study reports are available publicly on our website, and I'm happy to provide those and also answer any questions. Thank you.
Wow. Questions, committee? Thank you so much, Susie, for that report.
Ron.
Yes, sir.
Thank you for your presentation. The things that you mentioned, has there been any action taken by the FCC to get any of these under control?
I'm so glad you asked. So my colleague, Randy Weinstein, will actually give a few notes and his thoughts. And we have been doing a lot of work both in our enforcement divisions, and we are working diligently also on next steps of our study and hope to provide updates as soon as possible.
Go right ahead.
Recommendations, if you come up with any recommendations.
So we believe that policymakers have reason to explore this space, but at this time, our two prior reports do not make recommendations to state legislatures. They do describe PBM market structure, contracting practices, reimbursement methodologies, and economic patterns, but at this time, I am not able to make recommendations.
Thank you. I believe you mentioned Randy Weinstein. Is he up next?
Yes, I see he is here.
Good deal. If we could have, thank you so much, Susie, for the presentation. And we're going to have the attorney for the Bureau of Competition, Randy Weinstein, if you are available.
Indeed, I am. Thank you. Can you all hear me?
Yes, sir.
Terrific. First, I'd like to echo Susie's thanks to Mr. Chairman and the committee members for inviting us to speak today. I'm here to talk in particular about one of our enforcement actions, which we refer to as the insulin litigation, and the settlements, the public settlements that we've entered into in that matter. I worked on both of those as an attorney in our healthcare division. A couple disclaimers first. I have to provide the same disclaimer that Susie provided, which is that the views I represent are my own and not necessarily those of the commission or any individual commissioner. And my second disclaimer, I'm sorry that I don't yet have any Mercer Bears, but my oldest is only 7 years old, so we have a couple of years until we make that decision. Okay, so what I'd like to talk with you again today about first is the insulin litigation and then the settlements that we entered into. Let me begin with some background. Following an investigation, the FTC sued the 3 largest PBMs, Express Scripts, Caremark, and Optum, alleging that they created an opaque and artificial system for pricing drugs that enriched the PBMs while driving up costs for American patients and businesses. Here's how that worked. One thing that the PBMs do is they negotiate drug prices with manufacturers on behalf of the PBM's clients. Those clients are generally either health insurance companies or employers who provide health coverage directly rather than working with a health insurance company. We refer to those clients as payers because they are generally responsible for paying the portion of any particular healthcare claim, like the cost of provider care or here the drug cost that is not borne by the patient. At a high level, PBMs negotiate drug prices by trading prescribing volume for lower net prices. The volume comes from the PBM's control over drug formularies, which sort drugs into coverage tiers that incentivize patients and prescribers towards certain drugs and away from others. The net prices are a reflection of the rebates off of the manufacturer's set list price, which in the industry is referred to as WAC, or wholesale acquisition cost. PBMs have historically benefited from this structure in one or more of several ways. First, by keeping a portion of the negotiated rebate. Second, by charging fees to manufacturers based off the drug list price, or all of the above. The basic allegation in this complaint was that this dynamic, negotiating favorable formulary placement in exchange for rebates off of a manufacturer set list price, or otherwise using a percentage of the list price as a basis for various PBM fees, first, created a system that incentivized manufacturers to artificially inflate the list price. Second, it disincentivized a market-based fix. When manufacturers tried to introduce lower list price versions of their drugs, the PBMs gave favorable formulary placement to the high list price versions and excluded or disfavored the lower list price versions. And third, this dynamic harmed consumers whose prescription drug cost was based on list price. What do I mean by that? Well, if you have insurance, the payment that you make for a prescription drug generally reflects one of 3 payment types. The first is a copayment, which is a flat fee that's not based on list price. The second is coinsurance, which is a percentage of the total cost and generally does reflect list price. The third would be a payment made against a deductible. In some plans known as high deductible health plans, the patient pays the entire cost of their health insurance until their deductible is met. Here, the patient cost of the drug generally reflected the list price and occasionally resulted in a scenario in which the payer would actually receive money from the patient because the patient's out-of-pocket cost was greater than the net price paid by the insurer. We allege that this conduct violated Section 5 of the FTC Act. The complaint focused on insulin, but this dynamic was not limited to insulin. Fast forwarding, we have now entered into settlements with ESI and Caremark that have been accepted by the Commission and published for public comment. As the FTC has recognized in a court filing, the Bureau of Competition has also reached a proposed settlement with Optum, but the terms of that settlement are not yet public, since the settlement has not yet been accepted by the Commission. So today I'm going to focus on the settlements with ESI and Caremark. Those settlements have the following high-level features, many of which I believe respond to the issues raised by Representative Carter. First, the PBMs cannot give preferred formulary placement to a high list price version of a drug over a low list price version where the net price of the low list price version is the same or lower. This ensures that patients have the option to purchase the low list price version when that is the more affordable choice. Second, the PBMs, as part of their standard plans offered both to employers and through their affiliated insurers, must base the patient out-of-pocket cost for the deductible and coinsurance based plans off of net price rather than list price. Third, in their standard plans, the PBMs will no longer engage in spread pricing, whereby they charge payers more for a prescription drug than what they pay to reimburse the pharmacy for that same drug. Fourth, in their standard plans, the PBMs will no longer receive compensation from drug manufacturers that reflects a percentage of list price. Fifth, the PBMs must provide covered access to the direct-to-consumer pricing offered by TrumpRx. Sixth, the PBMs must disclose to payer clients, as part of their respective standard plan offering, drug cost and claim level reporting and payments made to other middlemen like consultants and brokers. Seventh, the PBMs must implement and/or maintain insulin affordability programs. Such programs generally cap at $25 a month supply of insulin. Eighth, the settlements also respond to longstanding concerns about PBM reimbursement policies raised by retail community pharmacies. To address these concerns, the PBMs agree to reimburse community pharmacies at their actual cost plus a dispensing fee or some approximation of actual cost if that information is unavailable. Ninth, the PBMs agree to appoint a monitor to ensure compliance with the settlement's terms. Now, those are the features that both of these settlements share. There are a couple features that I just want to address briefly that are sort of unique to each settlement. The Express Scripts settlement requires Express Scripts to reshore to the United States from Switzerland its group purchasing organization, which is called Ascent. The Caremark settlement includes a firewall to ensure Caremark only uses cost information obtained from retail community pharmacies to calculate that pharmacy reimbursement. This provision is important because Caremark, of course, owns CVS, one of the largest pharmacy chains in the country. The Caremark settlement also addresses complaints that Caremark stifled competition from digital hub pharmacies. Hubs are digital platforms that offer solutions to lower patient drug cost, improve access to medication, and support patient adherence, which basically means making sure patients take their meds. The settlement ensures that pharmacies and Caremark's networks can work with hubs and prohibits Caremark from interfering with any pharmacy hub relationship. This provision follows a report by the House Judiciary Committee finding Caremark may have violated antitrust laws by discouraging or prohibiting pharmacies in its networks from working with hubs. I'm happy now to answer any questions you all have about the litigation or the settlements. Thank you.
Members? Yes.
I want to ask a question. I'm not sure who to ask, but to our federal friends, Congressman Carter told us earlier that 2 states had passed legislation saying that the PBMs and the pharmacies couldn't be owned together. And from a federal perspective, I know this is fairly new, but from a federal perspective, have you been able to see that this has made a difference in anything? Or is there any advantage or disadvantage to doing something like that from the federal perspective?
This is not something that I am in a position to speak on as an enforcer. And I, to my knowledge, we haven't published anything publicly about any initial insight about the effect of those initiatives. But I defer to Susie and others.
Yes, we are aware of these, but unfortunately they are outside the bounds of our study as well. So at this time, I'm also not able to speak to it.
What about vertical integration? integration in general?
Did you hear the question? What about the vertical integration in general? Can you speak to that?
So based on our study, I cannot give any recommendations at this time, but we do believe that policymakers could have reasons to explore how PBMs and potential consolidation along the pharmaceutical drug supply chain impacts access to medicine. We believe areas of interest could include transparency, contracting practices, network access, and patient choice. The appropriate approach here, we believe, would depend on specific policy goals. And unfortunately, we cannot give specific recommendations at this time, but I am happy to circle back as well at a later date.
Other members? Wow. From the federal side, I want to thank Susie Jing and also Mr. Weinstein for taking the time to come in and get in front of us and really, for us on the committee here, we're drinking from a fire hose now. And I really appreciate the opportunity for the congressman to come in and bring us up to date and for you guys to spend the time with us. Thank you all again. We're going to move on with the manufacturers. They're going to come in and speak to us now for Sarah. I'm going to get the first three, if you will, so that we can go in order. Sarah Balog is from the Pharmaceutical Research Manufacturers of America, then Johnson & Johnson with Corbin Santos, and then UCB Pharmaceuticals with Bustos? With Marjo Bustos. So Sarah, you're up.
Thank you, Mr. Chairman and members of the committee, for the chance to be here with you today. My name is Sarah Balog, and I am Director of State Policy for Pharma. At the last hearing, the committee heard pharmacists' concerns about PBMs, and our industry shares many of these concerns. So we've just seen a wonderful presentation from the FTC themselves, so I won't belabor the amazing information that they shared with us. But I do think it bears repeating that just 3 PBMs control almost the entirety of the prescription drug market. Through years of the consolidation that we've been discussing this morning, the largest PBMs either own or are owned by the nation's largest health insurers. And negotiating on behalf of health plans, employers, and other payers, PBMs extract billions of dollars from pharmaceutical manufacturers each year. In 2025, those rebates, discounts, and other payments made by manufacturers of prescription drugs to PBMs and the healthcare supply chain reached $416 billion. Vertical integration is causing incentive for PBMs to increase utilization of certain drug products at affiliated pharmacies to generate the greatest revenue and their profits. And due to their large market share, PBMs exercise an enormous amount of influence in the prescription drug market, from negotiating rebates, setting up pharmacy networks, administering the pharmacy benefit on behalf of plan sponsors, crafting utilization management protocols, setting up formularies, and operating mail order, specialty, and/or retail pharmacies. The bottom line is that PBMs are supposed to help lower costs for medicines, but they often enrich themselves over the interest of patients and their health plan clients. This study committee provides the General Assembly a unique opportunity to examine these practices and help ensure that Georgia's patients are put first. The committee has also begun to examine the 340B program in Georgia. Congress created the 340B program in 1992 to help vulnerable patients directly access prescription medicines at safety net facilities. Through the program, biopharmaceutical manufacturers provided $100 billion in medicines at significantly reduced prices in 2025 to qualifying safety net hospitals and clinics, the covered entities under the program. But too often, patients are not benefiting. A lack of transparency and oversight has led to abuse of the 340B program. Today, large tax-exempt hospital systems, chain pharmacies, and pharmacy benefit managers are exploiting the 340B program by marking up medicines for profit, even though its intended beneficiaries were true safety net hospitals and clinics and the low-income and vulnerable patients they treat. The 340B program has strayed far from its safety net purpose, and Congress needs to fix the program to ensure that it is reaching its intended population. The true cost of the 340B program is that it has become a hidden tax on employers and their workers. Marking up the costs of 340B medicines for employer-sponsored commercial plans and patients with private insurance generates significant revenue for 340B covered entities. 340B hospitals collect 7 times as much as independent physician offices for the sale of medicines administered to commercially insured patients, and average spending per patient in the commercial market on outpatient medicines was more than 2.5 times higher at 340B hospitals than non-340B hospitals. The current design of 340B directly increases costs for employers by an estimated 4.2% or $5.2 billion due to the foregone rebates from manufacturers that would reduce the cost of the medicine. Employers in Georgia, including the state, as it provides coverage for employees and SHBP, pay an estimated $187 million more in healthcare costs due to foregone rebates as a result of the 340B program. I want to be crystal clear. The profit that covered entities generate, that they receive from that marked up price, is not paid by the pharmaceutical manufacturers. The manufacturer is required to sell the drugs to the covered entities at a steep discount, often pennies on the dollar. The massive amount of revenue that's generated when those covered entities mark up those discounted drugs is paid by insurers and ultimately by employers and patients at the counter, and in the cost of increased insurance premiums. So the 340B program has fiscal implications for state budgets and ultimately taxpayers. I'll give you an example from a neighboring state. An unprecedented report examining 340B hospital practices in North Carolina by the North Carolina State Treasurer found that North Carolina 340B hospitals charge state employees massive markups for oncology medicines. North Carolina 340B hospitals charged on average to patients in the state plan a price markup of 5.4 times the discounted acquisition cost that they paid for those very medicines. This resulted in billing the North Carolina State Health Plan a price markup on cancer medicines that was 84.8% higher than North Carolina hospitals outside of the 340B program. That's just one example of how the 340B program risks inflating costs for state governments. A 2025 IQVIA study found that a contract pharmacy mandate in Georgia, were it to pass, would be estimated to increase healthcare costs for employers and state and local governments by $25.9 million due to additional foregone rebates. I also want to just emphasize that the 340B program does not address healthcare access concerns. The potential for a pharmacy to contract with a covered entity does not impact a patient's ability to access their medicines. A pharmacy's status as a contract pharmacy has no impact on whether or not a patient can pick up their prescriptions there. There is also no requirement that a contract pharmacy pass along the reduced price of a medicine to the patient. Since 2010, the number of contracts with pharmacies has grown by over 12,000%. Between 2013 and 2024, over 200,000 contract pharmacy agreements were established. Adding to the concern these pharmacies are not improving access to medicines, studies find contract pharmacy growth from 2011 to 2019 was concentrated in affluent communities, leaving more at-risk communities behind. Additional studies have found that 65% of the roughly 3,000 hospitals that participate in the 340B program are not located in medically underserved areas. And in 2025, only 39% of in-state contract pharmacy locations in Georgia were in zip codes with an average household income lower than the state median. Some stakeholders have also raised objections to implementing a rebate model for 340B, and I just want to speak briefly to that where I can. We don't comment on individual company litigation or individual company business decisions, but pharma continues to have serious concerns about the persistent and often illegal abuse of 340B, which is driving up costs for patients, employers, and taxpayers. The law specifically prohibits hospitals from getting a 340B discount on a medicine that also generates a Medicaid rebate or for patients that do not qualify for the program. Yet both the Government Accountability Office, the GAO, and the HHS Office of the Inspector General have repeatedly said that these violations are widespread. Hospital abuse of 340B is one of the reasons the programs continue to balloon in size, letting hospitals make billions of dollars in profits from marking up the prices of medicines that they charge to employers, Medicare, Medicaid, and patients. Hospitals are taking a just trust me approach to requesting 340B discounts on medicines despite well-documented abuses. It's no wonder manufacturers have taken steps of their own to attempt to rein in rampant hospital abuse of this important safety net program. Importantly, in response to these issues, HRSA has now finalized their revised 340B rebate model pilot program, which will be implemented on January 1st, 2027. The administration's rebate pilot is a positive step towards improving transparency and modernizing the outdated 340B program. 340B is a $100 billion program that continues to operate with limited oversight and almost no accountability, allowing large tax-exempt hospitals, clinics, and their for-profit partners to generate profit without evidence that patients directly benefit. By leveraging data hospitals and clinics already collect, the pilot will help strengthen program integrity and crack down on fraud and abuse. We look forward to working with the administration on successful implementation, and we urge it to quickly expand the rebate model to all medicines in the program. Ultimately, 340B is a federal program that is governed exclusively by federal law, but Georgia can and should determine the impact of the 340B program's growth on taxpayers. Georgia has taken action to assess the impact of the 340B program on the state budget by directing the Department of Community Health to submit a report to the legislature on any impact to the state health benefit plan and Georgia Medicaid arising from 340B entity purchases, contract pharmacy arrangements, and general practices related to 340B drugs. The report will include an analysis of foregone rebates, the impact on premiums, and impact to state employee out-of-pocket costs. This information will be critical to informing the debate about 340B in Georgia. Other states like Indiana and Minnesota have passed laws requiring 340B covered entities to report annually to the state how much revenue they generate by marking up 340B drugs and how that revenue is used. States do not have the authority to create new requirements that are not in the federal statute or conflict with that statute. Whether manufacturers can be required to ship drugs to contract pharmacies for 340B providers is currently being litigated in multiple federal courts across the country. The 340B program has strayed far from its safety net purpose, and Congress needs to fix the program to ensure that it's reaching its intended populations. So thank you for your time, and I'm happy to answer questions.
Yes, Mr. Chairman.
I don't really have a question. I just hope we get a copy of your presentation because you have a lot of statistics in there that we.
Yeah, yes, sir, absolutely. We'll
Please
follow
don't.
up
Okay.
with all the data.
If we focus on patient, on the need, the availability, and the accessibility, from a research and development manufacturing point of view, what do you need to be able to help us provide the patient with the pharmaceuticals that they need so that it's available and accessible in a price that's not varying across whatever door they go through, that it's just a standard price? How can the manufacturing industry get to a point where they can say, this is what this costs? This is what we have to have, and we just deal in real numbers, real time for real patients.
Yes, ma'am. So the entity that decides what a patient pays, what their cost sharing is their insurance provider. Whether that's Medicare, Medicaid, whether that's employer provided insurance. The manufacturers don't set the cost sharing for what a patient pays. That's handled by their insurance company and their PBM.
And follow up. I realize you don't set the price for what they pay, but you do have a price of what it costs you to manufacture it, correct?
Yes, I mean,
So how is that how do we get to that point, get that information and get it to where we can then work with it with the insurance companies, which we have a little more control over through the insurance commissioner in Georgia, maybe?
Yes, ma'am. So again, 50% of every dollar, 50 cents on the dollar that is spent on a drug goes to someone who doesn't make it. So, the congressman spoke about the importance of innovation and the investment that our companies have made in researching these drugs, bringing these drugs to market, and providing, the innovative therapies and cures for America and for the world. It's a very, as we've already seen today, just from all of the discussion we've had so far, it's a very complex issue, and the back end claims processing and drug supply chain process is very complicated. So we are all united in wanting to ensure that patients have the access to the medicines that their doctors say that they need and that they can afford those medicines. We are all united in that purpose. With half of every dollar that's spent going to an entity that isn't the manufacturer, there's just limited ability for me to speak to how best to pull and push those levers.
I didn't mean to ask a question that was impossible. It's just, we've got to start somewhere. And it seems like starting with, what does it cost to make it, to do the research and development? And then how do we go from there? And that's my simple mind.
See how the best way to ask this, I know it's extremely complicated. You mentioned the PBM, you mentioned half of every dollar from that is going to the cost, not for the manufacturer of the drug, if you will. How exactly do the PBMs enter in this cost with 340B? How does that translate into an increased price to the consumer, the taxpayer, et cetera?
Well, it really speaks to the need for transparency. There is so much that is very opaque about the way that the 340B program is administered, because those contracts are private. We as the public, we as manufacturers don't have insight into contract pharmacy arrangements between a covered entity and a pharmacy. So they're often paid a fixed fee to dispense the drug. The PBMs are paid a fee. There's at every point, in the supply chain, those fees add up. And again, that's not going back into the pocket of the manufacturer. It's going back into the pockets of other vertically integrated participants in the supply chain. But I think to your point is that really the only way to get an answer to that question is transparency, is doing something like what we've seen happen in other states, where covered entities have to be very transparent to belabor the term, about how those how those contracts are, what they look like, and what they're, how much money they're making and what they're doing with it.
Thank you, Sarah. Members, thank you again.
Thank you.
Corbin Santos. Johnson & Johnson.
Good morning, Mr. Chairman, members of the panel. Appreciate the opportunity to be here. My name is Corbin Santo, and I'm a senior counsel at Johnson & Johnson Innovative Medicine. My work for the company focuses exclusively on 340B program matters, which span day-to-day business and operational legal issues, agency interactions, and legislative and policy development and advocacy at the federal and state levels. I appreciate the opportunity to be here today to share J&J's perspective on the 340B program and to explain our concerns with state laws that would expand use of contract pharmacies and limit manufacturer access to commercially standard 340B claims data. I'm happy to serve as a resource to the committee and share my knowledge on the inner workings of this program. But first, as you may know, J&J's history and commitment to Georgia go back more than 100 years, and it continues today. We currently operate 5 sites across Georgia for manufacturing, distribution, and administrative functions, including manufacturing in Athens and Cornelia. We have appreciated opportunities to host some of your colleagues and Governor Kemp at these sites. J&J directly employs more than 1,100 people and supports a total of nearly 8,000 jobs in the state. Georgia is also home to more than 750 J&J retirees. We've conducted 57 clinical trials in Georgia and partner with research organizations across the state. And in total, J&J has injected nearly $4 billion in economic activity in Georgia, and we're very proud to be part of the state's robust life sciences ecosystem. So turning to the 340B program, I want to state clearly and unequivocally at the outset that J&J strongly supports the original intent of the 340B program, which is to help vulnerable patients access more affordable medicines through the safety net providers that care for them. Many providers that participate in the 340B program perform critically important functions in their communities. Rural hospitals, federally qualified health centers, and other federal grantees often serve patients who face significant barriers to affordable medicines and healthcare. We recognize the challenges these providers confront every day and the important work that they do. Nobody should interpret J&J's position on state legislation on 340B as opposition to the program's fundamental mission. We support efforts to ensure that vulnerable patients have affordable access to needed medications and healthcare. We support appropriate use of the 340B program and preserving the program for the patients and safety net providers Congress intended to benefit. The question is not whether the program should exist. We all agree it should. Rather, the question is whether the program is operating in a manner that reflects Congress's original intent and whether sufficient safeguards exist to ensure that the benefits of the program are actually reaching patients Congress sought to help. Those are reasonable questions to ask, and we believe they deserve careful examination and legislative solutions at the federal level. J&J is a leading voice in these federal legislative efforts, and we encourage more covered entities to constructively engage in that process in Washington. I'll talk briefly about J&J's concerns with the pace of growth in the 340B program. The 340B program of today bears little resemblance to the program Congress created in 1992. Over the last 15 or so years, the program has expanded dramatically in size and complexity. Participation has grown significantly, with more than half of all U.S. hospitals participating in the program. The volume of 340B discounted purchases has increased substantially, surpassing $100 billion in 2025, which continues a pattern of 20+% annual growth that far outpaces growth in any other area of healthcare. No exceptions to that statement. And large healthcare systems operate extensive networks of affiliated facilities and contract pharmacies that leverage chain drugstores and PBMs to supercharge 340B revenues that ultimately benefit the stockholders of some of the largest corporations on the face of the planet. Yet despite this growth, there remains a fundamental problem. Neither manufacturers, Congress, state policymakers, nor the public can readily determine whether the increasing value of 340B discounts is producing proportionate benefits for low-income and vulnerable patients. To the contrary, in addition to the for-profit intermediaries I just mentioned, the available evidence suggests the 340B program is being used to pad the bottom lines of some of the largest and most financially high-performing health systems in the country, many of which use 340B to finance vertical and horizontal consolidation that deprives local markets of lower-cost independent providers and drives investment in care sites in wealthier and less diverse areas, sometimes at the expense of critical services available in less affluent and more diverse areas. Covered entities, and particularly hospitals, have substantial discretion regarding their use of program-generated revenue. While many providers, especially grantees, use these revenues to improve affordability for low-income and vulnerable patients, many hospitals aggressively resist any suggestion that 340B should be used to reduce out-of-pocket costs for these patients. This disconnect has contributed to bipartisan concern among policymakers, researchers, oversight bodies, and stakeholders across the healthcare system that believe greater transparency, accountability, and oversight are needed at the federal level. The public deserves confidence that a program of this scale is producing measurable benefits for the populations Congress intended to help. And I want to comment briefly on the differences of covered entities and their use of 340B. Not all covered entities participate in the program in the same manner. Too often, discussions about 340B treat all covered entities as though they operate identically. That is simply not the case. Federal grantees and many rural providers often utilize the program differently than large, sophisticated health systems. Many federal grantees serve highly specialized patient populations and operate with limited resources. Rural hospitals frequently face financial pressures, workforce shortages, and geographic challenges that differ substantially from those experienced by large urban health systems. J&J recognizes these differences. We believe policymakers should avoid one-size-fits-all approaches when evaluating the program and developing solutions. In our view, there is an important distinction between providers whose participation closely aligns with the historical safety net mission of the program and large, sophisticated health systems that have exploited gaps in authority and federal oversight to grow their use of this program far beyond its intent. Acknowledging these differences is not about assigning blame. It is about recognizing that policy solutions should be tailored to the realities of how different categories of covered entities actually use this program. A nuanced approach is more likely to preserve support for providers that depend on 340B while also addressing vulnerabilities that have emerged as the program has expanded. J&J's position on federal 340B legislative reforms reflect this nuanced view. And I would be remiss if I didn't mention, I know Congressman Carter had to step out, but his work on this issue and the bill that he has put forward with Diana Harshbarger from Tennessee, again, reflect a very nuanced view on how different covered entities and other players in the ecosystem around 340B use this program. And I would urge you all to take a look at that approach as you continue to review this program. On the topic of comprehensive federal legislative reform, J&J supports that type of reform that puts patients first. Reform should be patient-centered and include increased transparency, accountability, and oversight. There is bipartisan, bicameral recognition in Washington, D.C. that reasonable, common-sense legislation is needed to stabilize 340B for safety net providers using the program as intended, while addressing abuses by large hospitals and PBMs. Relevant to our discussion today and some of the legislation that's been put forward in the past, solving contract pharmacy utilization, claims data reporting, and patient benefit are all on the table as part of this federal effort. Unfortunately, there has not been enough engagement by large hospitals in Washington. Instead of engaging in these discussions in Congress, hospitals have set their sights on state legislatures, choosing to wield their immense political power and pressure against state lawmakers into passing legislation that gives them all they're asking for on contract pharmacy and claims data and asks nothing in return when it comes to program integrity, accountability, and patient benefit. There's virtually zero chance Congress would give hospitals this kind of sweetheart deal at the federal level. And there's good reason for that. It's because they understand in Congress there are significant challenges that need to be addressed holistically and with an appreciation for the program's impact on manufacturer participation in federal healthcare programs, the program's cost on employers, employees, payers, and patients, and its impacts on competition in the marketplace. While I understand your inherent desire to respond to the calls from your constituent hospitals, I strongly urge you to see each of these tactics for what they are. Bare knuckle pressure campaigns that ask each of you to pick winners and losers in a long-running battle that fundamentally is going to require some give and take from everyone in order to fix. And most importantly, that recognizes low-income and vulnerable patients should see far more benefits from this program than they do today. The single most effective way you can address these 340B issues is to direct hospitals and other covered entities to constructively engage in ongoing bipartisan, bicameral efforts to advance federal legislation in Washington, D.C. In the absence of federal action, which I've explained is due in part to hospital opposition, states have felt the need to act on contract pharmacy and claims data. We have significant concerns with state approaches that attempt to regulate these aspects of a federal program. And our concern is a threshold legal concern. 340B program is a federal statutory program administered by the Department of Health and Human Services under federal law. When states attempt to impose requirements that alter, expand, or interfere with the operation of that federal framework, serious questions arise under the Supremacy Clause of the United States Constitution. These legal questions are currently being litigated across the country, and courts have not yet reached uniform conclusions. I would be happy to answer any questions you have about the litigation concerning the other states that have passed similar laws. Beyond those constitutional concerns, however, we're concerned about the substantive policies reflected in many of these state laws. In particular, a number of states have sought to codify effectively unlimited contract pharmacy arrangements while neglecting to address well-known integrity issues associated with the use of contract pharmacies. Contract pharmacy networks have expanded dramatically over the years. With that growth has come increased complexity and increased risk. Two issues have long been recognized as central program integrity concerns. First, diversion, which means the provision of 340B priced drugs to a person who is not an eligible patient of a covered entity. And second, duplicate discounts, which is a situation where manufacturers provide both a Medicaid rebate and a 340B discount on the same transaction. Congress expressly prohibited these transactions because it understood that these risks would threaten the integrity and long-term sustainability of the program. Prior HRSA guidance recommends that covered entities implement safeguards to protect against these risks, including by having policies, procedures, and mechanisms in place. Also conducting annual audits of their contract pharmacies and disclosing non-compliance to the federal agency that oversees the program, HRSA, and affected manufacturers. Government watchdogs have repeatedly found covered entities do not adequately oversee their contract pharmacies. Yet no state law that has operated in this space and given unlimited access to contract pharmacies has also codified these minimal program integrity safeguards. Goes back to giving them all they're asking for and none of the obligations that go into ensuring compliance. Rather, to make matters worse, state laws seek to restrict manufacturers' ability to obtain the limited information necessary to identify and address these prohibited transactions when they occur. This creates a significant practical problem because manufacturers cannot detect duplicate discounts and diversion if they lack access to the underlying 340B status of individual claims. And this is a very critical point. Only covered entities know the 340B status of individual claims. Not even the federal government has access to this information. So unless covered entities share this information with manufacturers, there remains a very high risk of diversion and duplicate discounts. These risks are not theoretical. A prohibition on our access to limited claims data would foreclose any ability to identify and address duplicate discounts in Medicaid and the Medicare Drug Price Negotiation Program. It would also greatly limit our ability to identify instances of prohibited diversion. Now, I've held off on giving you guys a bunch of data points, and that's partly intentional, but you can't have a conversation about these issues without a little bit of data. So I'm going to tick through it, and we can certainly follow up in detail afterward. But I want to talk to you about just our exposure as a manufacturer on Medicaid duplicate discounts and duplicate discounts in the Medicare drug price negotiation program under the Inflation Reduction Act. So starting with Medicaid, a recent analysis found that at least 3 to 5% of 340B discounts and Medicaid rebates, are duplicated, which resulted in up to $2.1 billion in prohibited duplicate discounts in the year 2020. I don't have to tell you how much this program has changed in the last 6 years, but suffice it to say, it has grown by more than 20% in each of those years, suggesting that the incidence of Medicaid duplicate discounts has also grown dramatically since then. Just looking at J&J's own analysis of the very limited claims data we do receive under our current contract pharmacy policy for the most recent 3-year period, we found more than 16,500 340B claims that were duplicated with Medicaid rebate claims. This amounted to more than $22.4 million in potential Medicaid duplicate discounts during that period. And again, that doesn't include anything other than the very narrow subset of hospital claims we receive under our contract pharmacy policy. That doesn't include 340B claims submitted by grantees at all, or hospitals that have opted out of our policy, which I'll touch on in a minute. On the Medicare drug price negotiation program, researchers have estimated that manufacturers could pay more than $4 billion in duplicate 340B and maximum fair price discounts just in this year. And that amount could grow to more than $5.2 billion in 2027. To date, pharmacies have classified fewer than 0.5% of MFP claims, maximum fair price claims, as 340B eligible, despite estimates suggesting that 10 to 12% of these claims are actually 340B eligible. Classifying less than 1%, but the universe of eligible claims as 340B that should be tagged as such, 10 to 12%. Because of this under-identification of 340B claims, J&J estimates that it has already paid over $90 million in duplicate discounts on 340B eligible MFP claims for our 2 drugs, Stelara and Xarelto, just since January of this year. And approximately $2 million of that amount has been paid to entities here in Georgia. Looking at diversion, even with the limited claims data that we receive, again, from hospitals that choose to participate in our contract pharmacy policy, J&J has identified more than 10,200 duplicate 340B claims submitted by distinct covered entities. This occurs when multiple covered entities claim 340B pricing on the same drug dispense, despite HRSA guidance expressly prohibiting that. This occurs because covered entities use overbroad patient definitions that essentially consider patients to be patients of multiple covered entities simultaneously. How that works, I don't really understand. And they layer on extensive contract pharmacy networks on top of those definitions. And when you combine that with a lack of oversight and enforcement, this likely results in prohibited diversion on a scale we can't even begin to quantify. If policymakers wish to ensure program integrity, all stakeholders must have appropriate tools to identify and prevent improper 340B claims. A policy framework that expands contract pharmacy activity while simultaneously limiting access to data needed to identify compliance concerns risks worsening the existing vulnerabilities rather than addressing them. And before wrapping up, I wanted to provide a few additional points about J&J's 340B activity in Georgia. It's important for the panel to understand that currently none of the largest 340B hospitals in Georgia participate in J&J's contract pharmacy policy. This means that these hospitals access 340B discounts on drugs dispensed by an unlimited number of contract pharmacies today. When they seek to replenish the inventories of these contract pharmacies, The hospitals take in 340B discounted replenishment stock at a central in-house pharmacy and then redistribute that stock on their own to their contract pharmacies. And these hospitals do not provide the claims data to J&J. So in Georgia, hospitals effectively have unlimited access to J&J's drugs at their contract pharmacies, and J&J has no ability to engage in Medicaid deduplication or maximum fair price deduplication or diversion scrubbing that we perform when hospitals in other states provide claims data under our policy. The ability of 340B hospitals in Georgia to circumvent our policy is reflected in the unabated growth of our 340B sales since before that policy was implemented in 2021. Our average annual 340B sales growth in Georgia is 17%. More than half of our statewide 340B sales are to 2 large private hospitals in Metro Atlanta. More than half of our statewide sales to 2 entities. There are hundreds of covered entities in Georgia. To conclude, I want to thank you for the opportunity to appear today. Johnson & Johnson supports the original mission of the 340B program, and we are working hard to ensure the program is serving the patients Congress intended to help. We believe comprehensive federal legislation offers the best path forward, and a federal program requires a federal solution, one that balances the interests of manufacturers, covered entities, employers, taxpayers, and most importantly, patients. Thank you, and I'd be happy to answer any of your questions.
Members. Is Grady one of those hospitals?
Of the 2?
Yes.
No.
No, okay. Interesting. Since we have hypothetically, since we have the highest drug prices in the world, hypothetically, if Congress does something to fix the problem, if you will, as coming from a perspective of the manufacturers, can we expect drug prices to go down?
That would certainly be the empirically correct thing that would happen. Yes. Any suggestion that providing $100 billion in discounted products every year that's valued at the list price at nearly double that, constraining that program to its original intent and reducing that exposure, the idea that wouldn't impact drug pricing decisions, I think is a little naive. I think it absolutely would.
Other questions? Thank you, Corbin.
Thank you.
Mary Jo.
Good morning, Chairman and members of the committee. I want to thank you so much for the opportunity to participate in this discussion today on the 340B drug pricing program, and I'm honored to be here, truly honored to be here. My name is Mary Jo Bustos. I serve as the head of government pricing and reimbursement at UCB, a global pharmaceutical company with U.S. headquarters located in Smyrna, Georgia, outside of Atlanta. And we are inspired by patients, driven by science to the concept of studying and coming up with new medications to help patients, focusing on innovative medications for people living with severe neurological, immunological, and rare diseases. That's where our company focuses our attention and our research. UCB has maintained a presence in the United States since 1930s and established our U.S. headquarters in Georgia in 1993. We continue to expand that commitment in the state, including a new biologics manufacturing facility in Gwinnett County that represents the largest manufacturing investment in UCB's U.S. history. We believe that the 340B program can be strengthened through greater transparency, accountability, and oversight to ensure that 340B benefits are reaching patients and communities the program was designed to serve. You've heard that several times today about the original intent of the program. In preparation for our discussion today, UCB took a look at our 340B data specific to the state of Georgia, and we looked at our, I'll call them our staple products that have been on the market for a while. The numbers I'm about to share with you have nothing to do with launch products over the last few years. These are staple products that have been on the market for many, many years. And we looked at data from 2020 through 2025, most recent data available. 340B sales grew in the state of Georgia for UCB products, those staple products, by 170%. In that same period, our commercial sales in the state, again, the same products, commercial sales only, grew by 61%. I believe that our sales data indicates the challenge and the scope of the issue that we've all been discussing regarding the 340B program today and the concerns that we have with the integrity of the program. UCB supports the original intent of the federal 340B program. As discussed, Congress created the program in 1992 to help safety net providers stretch limited resources and improve access to care and medicines for vulnerable and insured patients. As discussions about the program continue across the country, it's important to maintain consistency and clarity for all stakeholders so that the program can maintain its original intent as discussed. We look forward to being a part of the constructive partner in the conversation and sharing our perspectives with the committee today. And I'd be happy to answer any questions you may have.
Yes, ma'am.
I find the information you presented about the 170% growth for the 340B program and then only 61% for commercial. My question is, why?
That's a great question. I don't know why. I would say that the general belief is that there's not sufficient transparency in the program. You've heard from many of us today, many stakeholders today talk about the need for more transparency. The gentleman from J&J talked about the fact that without claim level detail, it's very difficult to tell where product is going and how it's getting there. And so we're looking for more transparency to help answer that why question.
Do we know if this, because you've had commercial growth, so was that because, do you know why that growth occurred? Was it because we have a larger population?
It's a host of things, growth in population. These were dollars, so there are price increases that do occur sometimes over time. The 340B program is also seeing some price increases over time depending on what's happening with pricing. So that's incorporated in both data points that I gave you. But as to the exact reason why we're seeing such an exorbitant growth in the 340B program, there is a concern about bad players. We've talked about the potential concern with bad players. Some of the examples you've heard earlier may be contributing to that as well.
Thank you.
Mm-hmm.
Chairman. So I'm a little confused because you're saying that there's growth, but then you also said there's been cost increase. So your unit sales, maybe that's a truer definition of the increase. And I would be curious on that. I'm not trying to defend anybody, but if
Understood.
we're trying to throw somebody under the bus, we need to be accurate in how we throw them under the bus.
Understood. When I mentioned any price increases, that is consistent of both for the 340B program and our commercial pricing. As been discussed, price increases do occur. I mean, I don't want to be naive and pretend that they do not, but they impact the programs in a similar manner, whether it's commercial or the 340B program. And yet, even with any changes in price, the 340B program has significantly grown well beyond what we would expect it.
So is it a certain class of drug, or can you name some of the drugs that y'all manufacture?
I don't have the drugs in front of me. I can certainly get that for you. It is not a particular class of drug. It's just, we tried to look at products that I would describe as staples products that have been on the market for many years. Nothing that was recently introduced to the market or anything like that. We didn't want to skew the data with something that hadn't been fully established.
To your knowledge, are there any states that take a look at the 340B program at the state level as far as like their Medicaid programs or their state health benefit programs? Do they have any filter in there to get a snapshot of what's going on with the sharing of these incentives?
You're talking about state programs
Yes.
specifically? Not to my knowledge, no. I don't have visibility to the information that's available to the states.
Maybe we need to look into that. Thank you.
For coming today and appreciate the presentation.
Thank you so much.
Next three, we're going to do HEAL Collaborative. Howard, if you'll come on down, and then the MTS Sickle Cell Foundation, and then Bristol Myers Squibb. Howard Mosley, representative. Former House of Representatives. House trained, we call it. Welcome, Howard.
Thank you, Mr. Chairman. I came here with my green suit on because, Ron Stevens, those of you who served with him know, is the most stylish guy in the General Assembly. So I wanted to make sure I represented when I came here today. All right. Mr. Chairman, members of the committee, I want to thank you today for allowing us to testify. Good to be back with you guys. I'm a CPA and a board member at HEAL Collaborative, and I serve in this august body, and I don't want to waste your time or my time. And I used to sit where you're sitting, and we really wanted to know how the numbers people gave us, whether or not they added up. So I want to start real quickly with a patient story, and it's really not a statistic. So in our organization, we work with a woman. I'm not going to give her information for privacy's sake, but she was a breast cancer patient at a 340B hospital here in Georgia. Her next infusion was held up primarily because she couldn't pay for the copay. The drug at that time was being provided by that hospital at a steep 340B discount. She is the exact patient that this whole committee set up to deal with. And at the end of the day, it really is about the patient, because they're the ones holding the bag at the end of the day. And so that gap that we want to talk about today, how do we take care of those individuals? So my testimony today is going to be around that. Now, I mentioned my CPA license primarily because it shapes how I'm going to ask you to think about that gap. So an audit doesn't start by asking whether an organization has good intentions. It starts with a narrower vision. Can the numbers independently be verified? Do they show what everyone believes that they show? And right now in Georgia and nationally, we really can't verify the numbers. Federal law imposes no requirements that entities, how they use 340B savings, and no standard method exists for measuring whether patients like the one in my story are actually reached. We built really a $100 billion enterprise based on the honor system. So HEAL Collaborative examined information that we could get from data that does exist. And so partnering with Magnolia Market Access, looking at covered hospitals nationally between 2014 and 2022, hospital assets per bed grew on average by 40%, while uncompensated care per bed actually dropped by 15% per bed. So 48 states saw hospital assets grow, and only 15 states saw where those uncompensated care costs also grew with that. And so the pattern looks like it is savings are accumulating on the balance sheet rather with patients. So this committee's focus on PBMs matters directly here because PBMs sit on the other side of that 340B dollar. Many PBMs now reimburse claims dispensed through 340B contract pharmacies at reduced rates or impose network and accreditation fees that fall hardest on the community health centers, sickle cell clinics, and HIV service providers, all sitting in this room and are probably on today's agenda. Those policies are set through contracts most of us in this room will never see. If we're going to ask hospitals to open up their books, how 340B savings are used, then we should ask the same of PBM practices that determine how much of those savings actually reach the pharmacy counter. So Georgia, in its own version of this gap, roughly 30% of the contract pharmacies that Georgia covered entities use to dispense 340B drugs sit outside the state entirely. And a substantial share of the rest sit in more affluent areas rather than low-income communities that the program targets. So I raise this not to accuse any single hospital. I raise it because it's exactly the kind of finding that should trigger a closer look, and this committee currently has no audited mechanism to take a look at Georgia's own numbers. So as a CPA, I know what closes the gap like this, and it is standardized reporting, independent verification, and public disclosure, the same discipline already applied to every audited financial statement in this state. I'd ask this committee to consider 4 things. Number 1, standardized annual reporting from Georgia covered entities on 340B savings generated and how those savings were used in a common format authorized by the legislature that this state can compare year over year. Number 2, independent audit or attestation that the reporting above a savings threshold consistent with audit standards Georgia already applies to hospitals and nonprofit filing. So right now, if you're a nonprofit and your revenues are between $500,000 and $1 million, you have to have a CPA review your financial statements. If it's above $1 million, then you have to have those audited by a CPA. And it really is just looking at how do we, these savings be added on. These hospitals are already spending the money on audits. These entities are, so why not just go ahead and just extend the audit to look at this? The other thing is public disclosure of contract pharmacy locations and the patient population served so that this committee can measure whether or not the savings actually reach the communities the program was built for and not just trust that they do. And then finally, disclosure of PBM reimbursement and fee practices as they apply to 340B contract pharmacy claims so that this committee can see both ends of the dollar benefit, what the hospital receives and what actually reaches the pharmacy and the patient. Now, none of this requires the state to conclude today that 340B is failing or succeeding in Georgia. And that's the point. An auditor's job is not to decide in advance whether a program is good. Audits are used to build a record reliable enough that the people who use those financial statements to make credit and investment decisions can trust what they're looking at. I'm asking this committee to build that type of audit trail into its recommendations so that the next patient in my story's position has a program that can prove that it reached her and not just one that it was meant to. So Hill Collaborative's mission is to grow healthy, vital, underserved communities across Georgia, and 340B matters to that mission greatly. We would welcome the opportunity to work with this committee and its staff as you draft and audit standards to share the data behind what I have described today. I'd be glad to sit down and talk to you all about this. Mr. Chairman, I am happy to work with you. Let me know what I can do. I'm here to help. I'm like the government.
I got to tell you, we miss you very much in the House of Representatives. You were a voice of reason across the time. And you still got that yellow sports car?
Yes, sir. Yes, sir.
Thank you, Howard, for coming today.
Well, thank you. Thank you for the work that you guys are doing. And Debbie, I miss sitting in front of you. I'd be glad to answer. All right. Anything? Butch? Nothing. All right. All right. Take care.
MTS Sickle Cell Foundation, come next.
Good morning, Chairman Stevens and distinguished members of this committee. Thank you so much for the opportunity to speak today. My full remarks were submitted previously, so I will use my time to focus on the people most affected by these decisions, and those are the patients and their families. My name is Mapillar Dawn. I'm not a bear, but my husband is a graduate of Mercer University. I am the founder and CEO of the MTS Sickle Cell Foundation, and most importantly, I'm the mother of 3 daughters living with sickle cell disease. They're 22, 21, and 17 years old. My daughters share the same diagnosis, but the disease has affected them differently. My oldest daughter has experienced frequent pain crises and hospitalizations, a hip replacement surgery at the age of 19, pulmonary embolism, and she is now pursuing curative therapy. My middle daughter suffered a stroke at the age of 7 and has relied on monthly blood transfusions for over a decade now. She's had over a dozen surgeries. And then there's my youngest. She's currently hospitalized as we speak. She has experienced silent strokes and other complications that require her to have monthly blood transfusions. Within the last 2 years, she's had a major brain surgery and spinal surgery. Their journeys have taught me that patients with the same diagnosis do not necessarily need the same treatment. Treatment decisions must remain with patients and their families, as well as the healthcare professionals who understand their individual and medical histories. They should not be driven by undisclosed rebates, formulary arrangements, pharmacy ownership, or other financial incentives that patients cannot see or understand. For someone living with sickle cell disease, uninterrupted access to medication can mean the difference between stability or crisis, between remaining at home or going to the emergency room. Yet families routinely face prior authorization delays, formulary restrictions, unexpected coverage changes, specialty pharmacy mandates, and unaffordable costs. A patient stable on the therapy may suddenly learn that it is no longer preferred. These are not minor inconveniences. They can place a patient's health at risk. If PBMs truly are here to negotiate savings on behalf of patients, then I think it's important that we're able to see these benefits and the savings that they're creating for us. Georgia should require transparency, prohibit spread pricing, and I appreciate that Congressman Buddy Carter did so much education around that. He broke it down so nicely. And inappropriate patient steering. Georgia should protect community pharmacies and preserve timely exceptions and appeals. Financial arrangements should never override sound clinical judgments. That same patient-centered standards should guide 340B reform as well. The program safety net mission must be preserved, and providers who are genuinely serving vulnerable communities should be protected from discriminatory PBM practices. But patients should not simply be the justification for a discount. We should be able to experience meaningful benefit from all of these programs. At the MTS Sickle Cell Foundation, we have helped families avoid evictions, restore utilities, obtain food, travel to medical appointments, and much more. This work has taught me that access is not achieved simply because a medication appears on a formulary. True access means that we, our patients and their families, can obtain the treatment, they can afford it, and they can continue to receive that treatment without unnecessary disruptions. Respectfully, I ask that this committee pursue balanced reforms that increase transparency and accountability, preserve the safety net mission of the 340B program, and return clinical decisions to patients and their providers. Sickle cell families have spent generations fighting to be seen, heard, treated with equity. I think Georgia has an opportunity here to build a prescription drug system that truly serves our patient community. Thank you.
Swan, thank you. That's one of the best presentations I've heard in years.
Thank you. Thank you so much. Thank you.
And I want to thank this committee too. Every member serves on the appropriations subcommittee or the appropriations chair that every year funds sickle cell in every facet of, but you're right, that is an amazing presentation. Bristol Myers Squibb, Ashley Groom. There you are.
Nothing like following the best presentation, no pressure. Thank you, Mr. Chairman and members of the committee. My name is Ashley Groom, and I'm Director of Government Affairs for Bristol Myers Squibb, a company dedicated to transforming patients' lives through science. BMS is in the business of breakthroughs, the kind that transform patients' lives through life-saving, innovative medicines in areas such as oncology, hematology, immunology, cardiovascular, and neuroscience. We are in the business of helping patients, and I believe this legislature ultimately wants to do what's best for patients too, several of whom we've heard from here today. Unfortunately, the most recent proposal to expand the 340B program in Georgia does not accomplish that goal. Rather, it is nothing more than a government mandate that fails to improve patient access or affordability, driving up healthcare costs for all Georgians. When this committee met last month, you heard testimony that the 340B program didn't cost taxpayers a dime. That is absolutely false. Everyone in this room knows that 340B is a federally mandated program, and we believe it ultimately requires a federal fix. But what everyone in this room may not know is that in spite of being a federal mandate, this program is not federally funded. You may be thinking that's okay, Big Pharma can afford it. But that's not the truth either. Yes, drug manufacturers like BMS provide the drugs to covered entities at significantly discounted prices. However, the way those entities make money off the program is by charging payers, such as employers, state and federal government health plans, and patients full price. Stated another way, patients and payers pay full price, and the covered entity keeps the difference. To top it off, the lack of transparency keeps details on what that money is being used for shrouded in secrecy. Not only do payers pay the full cost of the drug, they're also losing out on rebates they've negotiated with their health plan, costs that ultimately get passed on to taxpayers, employers, and again, government health plans. Additionally, more expensive 340B drugs are often preferred over their generic or less expensive counterparts because covered entities can pocket the difference. That difference on average is about a 130% markup, a cost again being paid by everyone in this room. When I testified before the House Committee on Health in February of this year, the most current data at the time, which was from 2024, showed that 340B was an estimated $81 billion program, second in size only to Medicare Part D. Since then, HRSA has released 2025 data, which it shows the 340B program has ballooned into a now $100 billion program, which is a 23% single-year increase. For our company alone, in 2025, BMS provided more than $220 million in 340B discounts in Georgia, an increase of more than 20% from 2024, without commensurate growth in the 340B covered entities or patient population to justify such a significant impact. 97% of those discounts were extended to nonprofit 340B hospitals, while a mere 3% of those discounts went to grantees such as the federally qualified health centers who need the program the most. This is a stark reminder of how today's 340B program has evolved into a money-making scheme for major nonprofit health systems without any desperately needed transparency, accountability, or most importantly, direct benefit to patients. We support the program as it was originally intended, to lower costs for uninsured and underinsured patients, but unfortunately that mission hasn't been the focus of the program for many years. I'd like to go back and expand on the 340B program's cost to taxpayers, employers, and government health plans. And you heard some of these numbers earlier, and they are in the letter that I gave you just a moment ago. In Georgia, employers pay an estimated $187 million more in healthcare costs due to foregone rebates as a result of the 340B program. Those higher costs have broader fiscal consequences, including an estimated $14.4 million reduction in state and local tax revenue. And any legislation seeking to expand the use of contract pharmacies would further increase healthcare costs for employers and state and local governments by an estimated $25.9 million due to additional foregone rebates. Again, these are real costs ultimately borne by employers and taxpayers without any requirement that the corresponding 340B savings benefit patients. This legislature did pass language in this year's budget asking DCH to examine exactly how much the 340B program is costing Georgia's state health benefit plan. The budget language asked that those numbers be provided by September 1st. We know that several states have also enacted transparency laws to shed light on what is happening with this program. So far, 10 states have enacted such transparency laws, and we expect that number to grow. As Sarah touched on earlier, where visibility into these practices has been possible, the findings have been significant. In North Carolina, the state treasurer found one hospital system billed patients an average of more than $5,000 for oncology medications that they acquired for $500. For a single treatment of another cancer drug, 340B hospitals billed the state health plan more than $21,000 for the drug acquired for just under $8,000, generating an average profit of more than $13,000 per treatment. Multiply this by hundreds or thousands of patients, and you can see how the costs quickly explode. But the money is only part of the story. The other part is patient access. Large nonprofit hospital systems buying up smaller independent medical practices, particularly those focused on oncology and rheumatology, in order to increase their 340B revenue. This decreases patient access for patients who may be forced to drive longer distances to receive the same care in a hospital setting, which also costs more than other care settings, again, driving up costs. At the same time, these 340B covered entities don't provide meaningfully higher rates of charity care. In fact, over a third of 340B hospitals in Georgia fall below the national average of charity care provided by all hospitals. The narrative that restricting the number of 340B contract pharmacies impacts patients' ability to get their prescriptions is also not accurate. 43% of contract pharmacies are located in higher income zip codes, and 30% are out of state completely. The real reason covered entities want you to mandate that manufacturers provide discounts to unlimited contract pharmacies has little to do with patient access and everything to do with their ability to make money off that prescription. A patient can technically fill a prescription at any pharmacy, but a 340B covered entity is only going to reap a profit off that prescription at a 340B contract pharmacy. This is how the program has grown at such an unsustainable rate. With the number of contract pharmacies increasing 12,000% since 2010, 69 of those being tied to pharmacy benefit managers, reflecting the use of these arrangements for profit, not the vulnerable patients in Georgia who need it. Ask yourself, is this a federal program that has grown 12,000% since 2010 in need of additional growth mandated by the state legislature, or is it in need of federal reform? Thank you for your time today.
Thank you, Ashley. We have two more. Do we need a break or do we need two more before lunch? Members? Y'all okay with? Okay, then we'll move forward. AbbVie. And then lastly will be the Cancer Center of Middle Georgia. Thank you, Yvonne.
Hello. Good morning, Chairman and committee members. My name is Yvonne Barton, and I am the Director of State Government Affairs for the Southern Region for AbbVie. AbbVie is a American biopharmaceutical company based out of Illinois. We have over 55,000 employees worldwide and a little over 300 here in Georgia, which is home to our Allergan Medical Institute in Buckhead. I want to thank you again for the opportunity to come before your committee again. I know I was here last month. Today I'm bringing some more specific AbbVie data that I wanted to share with you all. I know a lot of this has already been covered by various different speakers, so I won't repeat myself. I'll try to cover these and move those along because I know I'm probably holding you up for lunch, so I'll try to speed that up. So next slide. So again, a lot of this information, I know you all have already been presented on what the 340B program is and why it was created, but I do want to focus on the original intent of the program. Originally, when it was created, it was to help about 90 safety net providers deliver care to vulnerable patients. That number has now grown to over 55,000 covered entities. Think about that number. It's a very, very large number. And because of that, we also have the fact that I know somebody else referenced this, and I think Congressman Carter did too, where there's no requirement as to where those funds are spent or whether they have to even be spent on the patient. So because of that, you have third parties that are entering this program that are benefiting quite a bit in the program. And every time the program increases, that benefit increases even further for that third party. Next slide, please. So in this chart, when we're talking about growth, I did want to focus on what that average annual growth is for the program. Nationally, it currently sits at 22%. But you can see by the graph that over the last decade, it's really grown exponentially. You see that gap even bigger and bigger. So the bright blue line at the bottom is the discount price that the covered entity receives. The top darker line is that list price. This is data from HRSA. So that gap is what you call the spread pricing value. So that is a value, that is the revenue that that covered entity can make with that markup. And so for Georgia, using our AbbVie data and the HRSA data, the state of Georgia accounts for about 2% of that 80 billion, so about 2 billion. Again, that's covering all 50 states. Georgia's about 2% of that. So the covered entities in the state of Georgia have made 2 billion in value from just in 1 year, 2025, from the 340B program. Just something to consider and think about. Next slide, please. So on this slide, this is more specific AbbVie data. So we are seeing the same growth trend with double-digit growth year over year in the state of Georgia for the AbbVie data. So that's the graph over to the left. On the right-hand side, we have some numbers from certain healthcare systems that we have from our data. Again, the financial benefit really is going to the large hospital systems and not your grantees, as others have referenced, and not patients. So one health system alone in the state of Georgia for our data, for the 340B discount value that we provided Georgia last year, accounted for 32% of that. The top 2 hospitals accounted for 49% of the entire amount that we provided for the state of Georgia in 1 year. So almost 50% went to 2 hospitals. And when you think about the covered entities, again, there are these 2 different types. You have your large hospital systems, and then you have your grantees, which was the original intent of the program. Your FQHCs, your Ryan White clinics, those other community health centers, those are the true providers that should be benefiting from the program. And so they make up about 64% of those entities in the state of Georgia. But when you think about the value, the revenue that is being captured by those grantees, they make up 8% of the entire amount. So 92% is going to your larger hospital systems. The grantees are only getting close to 8% of that revenue. Next slide, please. So another dynamic, another development that we've seen within the 340B program is prescribing behaviors. So when you think about that markup and that spread, naturally, because of the incentive in the program, you will see the 340B entities going for the brand product prescribing versus your biosimilars. So Humira, one of our drugs that went off patent back in 23, has 10 biosimilars in the market. And when we look at both environments, non-340B settings versus 340B settings, you see a big difference in that prescribing pattern. You'll see your 340B entities prescribing Humira more so versus your non-340B that will be prescribing biosimilars, which we should be seeing. That is the way the market works. You have a biosimilar get into the market, you have a generic get into the market, that's going to start getting prescribed higher because it's a lower cost. But within the 340B system or program, that incentive to have the bigger delta pushes the brand name forward versus your biosimilar because they're not going to make the markup the way you would with a brand name drug. Next slide, please. So again, with the 340B drug markups, this is a great example, and this is a real example from the Community Oncology Association. They conducted a study a few years back and did a survey of their hospitals, asked hospitals to report data on these different settings. So this is actual numbers that came from their hospitals. And so this gives you a sample of how a drug works in the various different settings and the markup and what that incentive is that's driving some of that cost growth within the 340B program. So your far right example is the 340B hospital setting treating a commercial patient versus Medicare. So in Medicare, you have a cap on the reimbursement versus commercial patient, then that hospital can charge the insurance plan or employer that cost. And that is the margin that that hospital will make. So on top of that, that charge is going to hit the employer. And then they're not going to get their rebate because that's another thing, you don't stack it. So you either get the 340, if you get the 340B claim, you're losing your rebate. So a lot of times employers are depending on that rebate with their plan to keep their premiums at a good level and hopefully not have that increase. But if you're losing the rebate, you're not going to have that cushion to help you with any kind of premiums or even in lowering the cost. One final item on this as well is that it also hits the enrollee, the beneficiary, the patient, because when they are charged the coinsurance, they're going to be charged on the $217,000. That's their coinsurance. It's going to be based off of that, not the $43,000 discounted price. It will be on that top price. So again, as others have referenced, everyone is paying for this 340B program. It is hitting everyone. It's hitting your employers, your health plans, the patient, your taxpayer. Next slide, please. So in Georgia, 66% of contract pharmacy partnerships are with the PBM. So I know we talk a lot about contract pharmacies, but I wanted to share this number with you again to give you that perspective that when you're thinking about contract pharmacies, and I know, in the state of Georgia, you're looking to help your independent pharmacists, the opening up a contract pharmacy mandate will only help the PBM. 66% of those partnerships in Georgia are with the PBMs or the larger chain pharmacies. So the bar graphs at the bottom give you the percentages of that 66%. So again, your large PBMs with CVS and Optum and Express Scripts as well. And the contract pharmacies usually retain about 25 to 35% of that 340B margin. However, there have been recent lawsuits by some of these covered entities suing the PBMs because they're claiming that the PBM is keeping up to 59, 60% of that margin. Next slide, please. Again, the PBMs are growing their role within this contract pharmacy space at a very significant rate. If you look at this graph, this is national data. So back in 2017, they accounted for 13% of the contract pharmacy environment. They are now at 45% and growing. In addition, you also have them like CVS, we have a quote there. They are referencing 340B revenue in their earnings calls. 340B program was never meant to produce profits for the PBMs, and yet they are referencing them in their earnings calls, which is another item to take note of. Next slide, please. So when we think about the PBMs, they have corporate entities, as referenced earlier with vertical integration. This gives you an overview of what that vertical integration is. And the red boxes highlight the direct 340B entities capturing revenue through that program. And again, you have your PBM, your contract pharmacy, and then your 340B companies. Each one of those is capturing revenue from the 340B program for that parent company. So when you look at that, you keep thinking, you can see an overview of who is really benefiting from the 340B program versus the original intent of the program for those vulnerable communities, for those patients that are really in need. The patient is not seeing any of this benefit. Next slide, please. In this slide, I wanted to give you all an overview of how much business has grown within the 340B program. In this slide, you see 3 columns. So the first one is your TPAs, your third-party administrators. These are software vendors that are doing 340B data mining. You have your contract pharmacies, and then you have your 340B optimizers, also a vendor that's capturing that 340B dollar. So these companies are just data mining your patient scripts to find that 340B revenue and to generate more and more with every script. And that should be a huge concern when you think about patient data health privacy. Their data, their scripts are being mined by these companies. Some of these companies go back 3, 4, even 5 years to try to find more revenue for 340B. We have examples of those experiences. And again, they're just scrubbing the data to look for that. And on the far right, you'll see a list of the top 25 Fortune 500 companies. 8 of the top 20 are in the 340B program and are in these companies. And the companies listed here is not even the full list of companies. We just put as many as we could on this slide. There are many more. Next slide, please. In this slide, we're just also wanting to highlight, and I believe somebody referenced this, 1/4 of the contract pharmacies in Georgia that are with the covered entities are outside of the state of Georgia. So when you're thinking about helping your communities, helping your independent pharmacists, helping that patient in the state of Georgia, that it's going beyond that. So your contract pharmacy partnerships are going to various other states, and there's no controlling that. Especially if you pass a contract pharmacy mandate, like the bill that you all were referencing or considering earlier this year, that will open up the floodgates even more so for the state. Next slide, please. This is another slide in regards to how Georgia employers and workers would be impacted with contract pharmacy mandate. And again, folks have referenced this. When you have a 340B claim, you're losing the rebate. So employers will lose that rebate, workers will pay more, and you will see that increase in cost across the board. Next slide, please. And finally, on my last slide, this is just an overview of the AbbVie dashboard. We are doing our best to really look at data, capture that data, share that with policymakers. We're more than happy to follow up with anyone that has any specific questions on this. But the one number I do want to call out is the top number. So over the last 5 years in the state of Georgia, the increase for our AbbVie discounts within the 340B program has grown 145% in 5 years. It's significant, and it continues to grow, despite the fact that we have put certain policies in place to try to control that. We are still seeing a rapid growth despite those types of steps that many manufacturers are taking. So thank you again for the time today. I hope I moved through that a little quickly, but I hope that was helpful. And I'm more than happy to take any questions you may have.
Thank you, Yvonne. Don't leave. No, Yvonne, don't leave. I got a question. Yeah. Hypothetically, if every single independent pharmacy that was using 340B today with their contracted entity, if they're, one of them, let's just say that they were taken away, and the vertical integration with the insurance company, the PBM, and the mail order house, which has mandatory mail order, could you see any savings at all, or a lack of participation, if you will, if the independents were taken away? Since basically, and correct me if I'm wrong, some of the pharmacies for these vertically integrated companies are out of the state of Georgia. They will just ship it to you, and the independents wouldn't have any participation at all.
And I agree. I mean, I don't think that would be a solution. I mean, you should be able to go to the independent pharmacy to be able to get that script. But again, I mean, the way that the 340B program has evolved is that it's not about where you're getting the script, it's about where that discount is going. So because there's no story out there where you're gonna find a patient that's supposedly 340, because I could have been a 340B patient. You could be too. We don't know that. We are not aware, because it's all done in the back end through the systems, through the adjudication, through the claims. It's all done through that. So the product is sitting in the pharmacy counter. The discount is the piece that gets connected, and that's where your 340B optimizer vendor, your software 340B vendor is scrubbing that data to find where they can capture that discount.
Thank you, Yvonne, very much.
Thank you.
Remember, we don't have any more on the first half. It is now 12:22. We're going to be back here at 1:10, and we're going to have lunch. Ladies and gentlemen, I hope you'll come back for the afternoon, and this will be the order. We're going to have the yeah, here we go. The primary care, federally qualified healthcare centers will be first. The AID Atlanta, followed by AIDS Healthcare Foundation, the Georgia Pharmacy Association, and the American Pharmacy Cooperative will come up last. We have two people that have signed up for short presentations as we end our day, and we have a sign-up sheet for those of you with a burning desire to get in front of the committee. And ladies and gentlemen, we will be back here shortly. Don't leave. There we go. Ladies and gentlemen, I think we're going to start the second half of the show. And we're going to start with Becky Riles, if you'll take the podium. And am I echoing?
Thank you. Chairman Stevens, members of the committee, thank you so much for the opportunity to present to you this afternoon. I am Becky Riles, representing all of the community health centers in Georgia, the federally qualified health centers, FQHCs, community health centers, FQHCs, that those terms are used interchangeably. Federally qualified health centers were started for the purpose of providing a medical home for patients close to home, so they could receive access to primary and preventive health care without traveling extensive distances. And in many cases in Georgia, patients can literally walk to the health center. In Georgia, there are 35 health center organizations, and they currently exist in 331 clinical sites across Georgia in 133 counties. So these are community health centers in urban areas, rural areas, literally, and you've got the footprint in front of you. What would it be? A presentation by Becky without a map. So the maps are in front of you showing of those 35 organizations, the 800,000 patients that are served at a health center each year. Those are patients, your constituents, who receive high quality health care. And those who are uninsured or underinsured are charged on a sliding fee scale. And that was part of the intended purpose. Health centers were begun in the 1960s by Congress, and they created it intentionally to be a public-private partnership. So the feds provide some federal grant dollars for the uninsured and underinsured patients who are seen at health centers. Patients seen at health centers are part of the organization. So each health center organization has a local governing board of directors, and at least half of those board members are patients of the health center. The idea being that the health center provides services that are needed to truly fill a safety net gap that exists in that community. Fast forward 30 years, Congress was so pleased with the success of health centers and the patient access to high quality health care that they created the 340B discount pharmacy program. Now, we've heard a lot this morning about transparency. Y'all are about to meet transparency. We've heard a lot about vulnerable populations. You're about to meet people who serve vulnerable populations every day. We've heard a lot about original grantees. I'm beginning to feel like we're in that Butch Cassidy and Sundance Kid movie. It's like, who are those guys? Who are those original grantees? So without any further ado, Mr. Chairman, I'd like to introduce you to Catherine McLeod, who is one of those original grantees of the 340B program. And in that statute, FQHCs are mentioned specifically, the intention being that patients have access to discounted medications. The health center uses the savings to turn it back into more services for patients. And most of all, patients are more likely to be compliant with their medication and the protocol in using the medications if they have access to them. I've heard You, Chairman Parrish and others say if you go to a doctor and you get a diagnosis, but you don't have access to your medication, you've only solved half the problem. So, Mr. Chairman, I would like to allow, if you would allow these health centers to come forward, share about the patients that they serve at their health centers, the nuances of the patients who are treated and seen from Macon to Savannah to Osceola by the Sea. And then we are glad to entertain any questions as you all would allow. So Catherine McLeod, CEO of First Choice Primary Care.
Thank you, Chairman Stevens, members of the committee. I appreciate the opportunity to be here. Again, I am Catherine McLeod. I am not a Mercer Bear, but our health center has part of our origin story has to do with the Mercer School of Medicine. Years ago, a new dean came here, Dean Job. She had worked in other communities where there were federally qualified health centers, and she couldn't believe Macon didn't have one. So she worked with some people in the community and provided a little bit of seed funding that, after a few years of community development work, created a board of directors that I stumbled into, and we wrote our first grant and opened our doors in 2007. So that's our original connection to Mercer. I'm a Duke graduate, so we have a different story. Again, First Choice, we started out in downtown Macon. We now have 8 clinical sites. One of those is in Warner Robins, real near the base. And we own a pharmacy that we bought the little building next door to our clinic. So we're there in a part of the community that the city of Warner Robins is trying to redevelop. In Macon, we have 2 school-based health centers we opened recently when our school district applied for grants through the Department of Education and the funding that the state provided. We provide care at a homeless day center. We have one site that is in East Macon. It's still considered Macon, but it's in Jones County. So really we have sites in those 3 counties. We do have a pharmacy in our downtown office that has been, has really become an integral part of what we're able to do for our patients. That pharmacy has gotten really busy. We're open on Saturdays. I think last year we filled over 50,000 prescriptions. We do daily delivery for both pharmacies at no charge to our patients. And you can pull, that's one of the things we do with our 340B savings. We also provide them with free diabetic supplies, convenience packaging, all those other things that we hope will help our patients get access to medications, but also continue to stay on what we have provided for them. We do have a network of contract pharmacies, some independents, including Graves Pharmacy here. We served a little over 11,000 patients last year. About a quarter of our patients are over 65. So we have a fairly large Medicare population in our health center, although a lot of our Medicare patients are under 65, they're disabled. 54% of our patients have been diagnosed with hypertension, and about a quarter diabetes. So that's a lot of the medications we're trying to help patients with. One thing I wanted to explain in our pharmacy, the way we do provide 340B medications. An uninsured patient comes into our pharmacy for, if it's an eligible 340B and if we wrote that prescription, we don't mark up that drug. We give that to the patient at the cost we paid for it. And then we have a fill fee, a administration fee that we base on what Medicaid reimburses us to fill a prescription. And that fee, we apply our sliding fee discount to it. As you all know, we have different levels for our sliding fee. So that's how we give the sliding fee discount, but we don't mark up the cost of the drugs at all. And we do expect our percentage of uninsured patients, it is going back up. When the Affordable Care, the enhanced tax credits for the Affordable Care Marketplace ended, we have a significant number of our patients that have gone back to our sliding fee program because they can't afford that insurance anymore. So that access to those medications is even more important for those patients. We currently have 7 physicians, 14 family nurse practitioners, 1 psychiatric nurse practitioner, 2 mental health counselors. We do a medically assisted treatment program. As well as our pharmacists that are integrated into our, like this morning, we started out the day with the provider meeting. Our pharmacists we include in that because they're really a part of our care delivery team. Our pharmacies experience, they're independent pharmacies. So we see those same challenges in our reimbursement and how PBMs affect our reimbursement for an insured patient claim. The contract pharmacy restrictions are really, this whole process is so convoluted, but the way I try and describe it to people is for a particular manufacturer, we can pick one contract pharmacy. So for Novo Nordisk, we look at our data and see where most of our patients are going. We are going to pick that pharmacy. Then for Eli Lilly, it might be a different pharmacy. Because of where our patients are going. Unfortunately, it's not likely one of those is going to be an independent pharmacy just because of the volume. So those contract pharmacy restrictions cut back on our ability to do business with independents, which we would like to do because we know those are people typically closer to our patients in the neighborhoods where they're living, and have probably been taking care of those people for a long time. We submit all this claims data. I was a little confused by some of the comments earlier about no data, but I don't know what happens in the hospital world. I just know that we are uploading claims. Well, I'm paying someone to upload claims. So these drug companies have all our claims data. We have to submit those claims within 45 days of the date they were dispensed. So there's a clock ticking. And that can be a challenge sometimes because there's a delay in getting all the data processed. I asked that we contract with a company to help manage our pharmacy and our 340B program, PharmD on Demand. They're based in Watkinsville. And they help us stay compliant with the program. I asked them to look at what the contract pharmacy restrictions, what impact that was having on us. In calendar year 2025, this does not include all our data because some of our contracts, this data wasn't available. But we could look at claims that were not deemed eligible because they weren't at one of our contract, the chosen contract pharmacy. Now that prescription, if somebody was insured, it got filled and the patient probably didn't know any difference. But if that patient was uninsured, I'm sure they felt the difference because they weren't getting the 340B price. But 476 people were affected. But it was 1,500 claims that were excluded in this partial data. And it reduced our revenue by $540,000, which for a small health center like us is a big impact. So it's affecting the patients, our ability to do business with our local partners in independent pharmacies, as well as our revenue. So what do we do with that revenue? I mentioned the delivery. One of the things that I think we've our patients have gotten great benefit from is doing clinical pharmacy, using some of our valuable pharmacist time to come out from behind the counter and sit down with patients and do patient education. We are going into some of the senior housing communities in Macon, where we already have patients, and sending a nurse practitioner, a pharmacist, a RN, and sitting and talking with patients about when was their last visit, going through their medications. Are they having any issues? Would compliance packaging help? And reminding them that we do deliver, and that taking half a day from the pharmacist time out of the pharmacy, we're paying for that time. And that's kind of thing we're using that 340B revenue to support. We are also, with our school-based health centers, we've had one at an elementary school that you could literally walk to from here if you walk across Mercer University Drive a few blocks. And then our two new school-based health centers, we are prioritizing pharmacy delivery for those locations. So if a child is sick, we see them in our school-based health center and get that. If a child has strep throat, we can get that antibiotic to them as fast as we possibly can, removing that transportation barrier and hopefully getting the child back, getting healthy back in school quickly. I hope that is some of that information is helpful. This 340B program is really critical for us to be able to continue to do what we're doing. Now I'll introduce my colleague, RB Tucker from Ocilla.
And while RB is coming down, question.
Yeah. If I understand you right, you have a variety in your 340B program in that indigent patients who cannot afford anything, you're giving them all the 340B discount. And your patients that are insured, you're using some of that 340B discount in your delivery programs and in other programs. Is that correct? Am I following you? Great. Okay, thank you.
One more. Sorry.
Okay.
But again, hypothetically, if without 340B, let's just say you got all these changes that are coming from the federal side. You mentioned compliance packaging. That stuff's not cheap. I suppose with the thin margins you've already got, that might be one of the things you'd have to get away from if a patient's taking 6 or 8 drugs. And if they're especially, I'm not going to say mentally challenged, but if they're like me and older, it's a real challenge to take more than one a day and make sure that your health is moving along. You probably wouldn't be able to do that.
Correct. That's something we do out of our Warner Robins office because we've got the space there, but it is, we're not charging the patient for the cost of the packaging.
Thank you.
See?
Good afternoon, Chairman Stevens and members of the committee. Thank you for the opportunity to speak about the 340B pricing program and its importance in rural Georgia. My name is R.B. Tucker. I'm the CEO of South Central Primary Care. We have 12 locations in the towns of Fitzgerald, Douglas, Pearson, Nashville, Valdosta, and Osceola. From the top, our very northern site to Valdosta, they're 90 miles apart. So we scan a good part of the south, right through the central part of the state. We are located in rural Georgia, where most people make their living providing raw materials for food, clothing, and shelter. So it's very important that they have health care. In 2025, we provided services for 15,921 Georgians, with 48,446 visits, of which 774 were virtual. We had 870 behavioral health patients and 164 patients that had substance abuse problems. We employ 4 MDs, 12 family nurse practitioners, and 2 licensed clinical social workers. Being I'm standing in Mercer, I married a Mercer Bear. And on the education standpoint, we collaborate with South Georgia Medical Center and run medical students through our locations. We're collaborating with South Georgia. Let me start over. We collaborate with the Medical College of Georgia, rotating students through our locations. And we're also collaborating with South Georgia Medical Center's residency program, where we are rotating family practice residents through our pediatric practice. We also provide clinical rotations for licensed practical nurses and medical assistant students from South Georgia College and Wiregrass College. From a pharmacy standpoint, we have 1 in-house pharmacy, and we contract with Walgreens, Walmart, and several independent pharmacies in smaller towns to provide discounted drugs to our patients who qualify. Having medicine that is affordable and nearby is vital to the well-being of our patients. Practicing medicine without medicine will not improve the health of anybody. The majority of our patients are obese, have hypertension, diabetes, depression, and anxiety, just like almost all the patients in the United States. The importance of 340B, a 340B allows community health centers to purchase eligible outpatient medications at discounted prices and use the funds to expand access to care. HRSA describes this program as a way to help safety net providers reach more patients and offer more comprehensive services to underserved populations. We at South Central use the revenue generated to fund 3 school-based health centers, along with behavioral health services and pharmacy delivery. As far as accountability goes, community health centers are accountable. We take our responsibility seriously. We comply with federal requirements and oversight, and we support appropriate accountability, transparency, and safeguards. We at South Central went through and passed a HRSA 340B audit in February 2025. And no, they did not find any duplicate discounts. It was extremely stressful, as there are so many rules that hinge on small details. But I will say the process of going through it made us better. We have an outside auditor that does an annual audit on our 340B program. And we review sample transactions on a quarterly basis on our contracted pharmacies. My concerns, I do ask that you recognize that changes that restrict the program could unintentionally make medications and healthcare less accessible to rural patients. Having us choose only one contract pharmacy would eliminate our patients' ability to access 340B medications at pharmacies like Morris Drug Company in Pearson, Colony Drugs in Fitzgerald, Swan's Pharmacy in Douglas, Wells Drugs in Osceola, Dogwood Pharmacy in Nashville. Please support policies that protect patients with continued access to 340B medications. We recognize the unique challenges for rural health centers. Allow appropriate in-house and contract pharmacy arrangements. Recognize 340B as an opportunity to reinvest in rural communities. We view 340B not simply as a pharmaceutical problem. It's a healthcare issue. It affects whether patients can afford medications, whether communities can maintain essential services, and whether where someone lives determines the quality of care that they receive. In conclusion, community health centers are committed to Georgia and making every healthcare dollar go as far as possible. Thank you for your time and commitment to the health of our communities. And now I'd like to introduce Albert Grandy, CEO of Curtis C. Cooper out of Savannah.
Good afternoon, Mr. Chair Stevens and the committee members. I know some of you know me, but I'm gonna give a little opening first to let you know our axe is basically to try to carve us out of this one contract pharmacy for the FQHCs, and I'll tell you why. I'm Albert Grandy again, the CEO of Curtis Cooper. I'm a bean counter by trade, so I'm a CPA. So since I've been here, and I've been listening to everyone, it appeared to be like 100 bean soup. We heard about PBM, hospitals, manufacturers, and others. So can we just put us aside? Let's just be a cup of Navy bean soup for the health centers, okay? So we can look at it that way, and it can make it a little, we can understand better. I've been involved in health centers for 40 years. It may not appear to be that way. Me and Congressman Carter came up the same time at 10. So I was in health centers when they started 340B. 340B started initially for community health centers and rural hospital as a purchasing program. Then it became a revenue generating program. So that's how it all started for 340B. So I'm just gonna give you a brief history of Curtis Cooper, and so you can understand about FQHC, how it works with where we are. If you can, so right now we've been in business 51 years. We have probably 33,000 patients, 110,000 visits. We're the largest primary care provider for indigent care in Chatham County. Currently, we moving more into, we in Bryan County as well, and in Effingham County. Got 250 staff, 42 medical providers, 5 dental, got 8 behavioral health. We're extending that more, where we have a collaboration with Effingham Hospital, and we're doing more work in the school district. And we have patient-centered medical home level 3. That means we get the highest recognition and for quality, where most of the health centers in Georgia are. And we integrated our behavior health 11 years ago. If we go to the next, you can see our service area. So you have maps, so you can see that we're RB saying that his area is more rural and it's covering other counties. So we have, as I go along, you see if it's one contract pharmacy, the areas that we do urban and rural, it'll be difficult for the patient to not to receive the prescriptions they need, and it create other issues for us for healthcare delivery, access, and financial. And I'll tell you what those are. We can go to the next slide. These are just our services, basically primary care. We a little different than most. We got OBs. We have 5 OBs. We got collaboration with St. Joe's Hospital. We got 3D mammogram, one of the few health centers that have a 3D mammogram, ultrasound, and the pharmacy, and just the proceeds from the pharmacy help us have these type of services. So we go to the next screen, and you can see these are locations. We had 16 locations. We in 34 schools in Chatham County, and we're in 17 schools in Effingham County where we use our mobile vans or telehealth, and that's how we see the patients that we see. We go to the next one. I know that Ms. Rouse has spoke earlier about if you seen one FQAC, you seen one. So it's 35 unique organizations across Georgia, 331 sites, serve approximately 800,000 residents in 133 counties. So I'm saying that just the impact of Curtis Cooper, you're looking all across Georgia for the individuals that we serve that's underserved, that's impacted. And if we just are regulated to one contract pharmacy, they probably have the same issues, which I know they would. We go to the next slide. And this is where it really matters, the impact of just limiting to one contract location. It should be noted that of the 80 billion that they spoke about across the country, and there's 100 billion, they're all health centers across the country, which is 1,500. We only make up 6%, so about $4.8 billion. I know earlier it was another presentation said with 2 billion just in Georgia, so you know our percentage even lower than that. So we are not the ones that making all of the money, okay, out of that. So 80 billion, all health centers across the country just serving the 50, 40, they say 50 million people. We only make up 4.8 billion of that whole 80 billion. So all community health centers. So it's even less in Georgia. So if I drill down what it means for us, it's going to be a direct impact on our local independent pharmacies. That means that if we only can have one, you saw the service area, how many people we serve, then you only have one, then it's difficult, as both Catherine and RB said, you can't just have one. Which one you're gonna use for which drug? It's like a Scrabble board, and you can't spell, so you don't know which way to go. Then you got limited competition, because most independent pharmacies, they can't compete with the big chains. What you already said about the PBMs and how they drill down, because you're not gonna be able to compete with them because they have more access to more prescriptions. Then we get to the real thing is the patient access concern. The patients won't have access to pharmacies in the rural areas. They have relationships with local pharmacies in that area, with the individuals that they talk to on an ongoing basis, that they probably grew up with, family people. They may not stock the specialty meds that you could get from other pharmacies. What happens then? Right. What happens? That's the question. So that's what the patient is faced with and will be faced with. What happens? And then it said, then you got mail order. Then it may start mail order. Then people are not used to mail order. That's another issue that I'm talking about, the patients, people on HIV meds. What happens with them and your family, and people with emergency meds? So you have different relationships with different pharmacies. You can call on them and say, hey, can you do X, Y, Z for this patient? And we'll work it out because we know for the care, but you may not could do it if you only have one. So those are the things for the patient concern. And then the reporting, that I know it's been said that a manufacturer said it only takes X amount of time, but it's taking us, we have to do it now, about 16 hours. So you got to, every claim, you have someone in the pharmacy and someone in accounting to make sure the claim is right, so you don't get, because then they can cut you off from it, and then you're going to be reimbursed for it, or you can't order from it. Then we have to upgrade our system. We have to upgrade all our pharmacy systems now. Everyone have to, for reporting purposes, so we have another administrative financial burden. Then also, it just restrict from a business model for the health centers. I'm going to show you what we use our proceeds from the FQAC for the whole network. We got 2 in-house pharmacies, and we have 10 contract pharmacies. We have multiple sites. So you saw a service area. So if I'm cut to one, then I don't know how someone, if geographically in Pembroke, how will they get to our pharmacy in Savannah or anywhere else, vice versa? If you only have one, or Effingham, where we deal with behavior health, we deal with substance abuse, we making an impact, then that's changed, then we limit it to one. So that takes the whole financial picture out for the pharmacy network. So that created another issue. And then I would say that our revenue savings from 340B with MB impact about $1.5 million annually. That's estimated. But who benefits from that savings? Is that if you purchase in 340Bs is lower, then obviously the manufacturer in terms of retail, they're selling the same drugs. The only time you make money off 340B for a community health center is off commercial patients or Medicare Part D. You don't make off Medicaid, you don't make off indigent patients. So we just do a cost plus a handling fee. So that's the only money we make off it. I don't know about the markups and things of that nature. So I don't know. That's beyond me. I'm just a bean counter. You know, I'm just dealing with Navy beans. That's beyond me. So we go to the next slide. So this is what we use our savings for. We have 5 mobile vans that we take and go service the schools in the surrounding area. So if anyone got a mobile van, you know it's like your first used car. You're gonna always have some maintenance issues. So just the generators alone, they burn out. They don't get but X light. So they 5 to 15,000. So just think you got 5 vans moving all around. So tires, gasoline, we got equipment on there, dental equipment, other type of equipment that moves on there. So you gotta have that changed out. So that's what we use it. We have dental services for seniors. We do affordable dentures for people quality of care, their health. If you can't eat, you can't chew, then you have other issues. We provide transportation for the urban area for Uber. You know, RB say they don't have Uber there, you know, Scylla. But we do gas cards. So we try to do things that we know that we can help the patient with the proceeds we get. We do free meds for anyone that come in for that day unable to pay. Any senior that comes that day that we know we might have a generic or some other drug that we can give them that day. It don't make any sense for somebody to come in and you prescribe some med and then they don't have it and end up in the emergency room. It just don't make sense. Or a mother or father with kids, they come in, we provide them with that first one, then we work with them. We have the people for a patient assistance program. So those the programs going to be reduced. Then we have classes to address chronic disease that are free for diabetes, hypertension, obesity, etc. We can't give those anymore because, you know, I had to pay the doc extra and things of that nature and that cost. And then we have staff, we increase out for to address the infant mortality in Georgia and the substance abuse. Those things are, and that's have the greatest impact in the rural. And so the next slide here, the impact that nobody wants, we cannot put a cost or value for a loss of a life for the lack of just providing prescription drugs. Because individuals will go into some type of untoward event in an emergency room because they can't get a med. Because we doing things, we've been put into that cycle where we're trying to get out for community health centers. They're just speaking about community health centers. I don't know about hospitals. Talking about community health centers, that we limited access to our services that we provide. Even though individuals say it may not limit access, but it does. So transportation is crucial. And then I have one other slide that just want to thank you for presenting this opportunity today and your continued support of the Georgia FQAC. I can entertain any questions you may have.
I've got one if you don't mind, and it's just kind of a broad one. We keep hearing about the PBMs for the 340B. Other programs like private insurance, Medicare, Medicaid, Do they have practice management associated with them?
I'm not aware of that.
Okay.
We just, we just
We-
got a report like to the manufacturers. We got, not to my knowledge.
Okay.
They're just a conduit.
So with those other programs, whether it's private, Medicare, Medicaid, do you have audits that you have to do?
Oh, yes, we have an annual audit every year. We probably audit more people than not, from Georgia, narcotics, DEA. We have everyone to come in and audit us for different things we do and around the program. For the FJC, RB have specifically for 340B as well.
And are all of those different? All those audits are done by different people and they're different audits?
Yes. You had the main one for the feds was required to audit our 340B program is that we are in compliance is with the 340B program that is intended for the individuals that should be receiving it. Because you got certain things you got to be qualified.
Where I was going with all of that, so that you'll know, Mr. Chairman, is if one of the things that was recommended earlier today was to have audits, then is there a way we could just streamline that? These folks don't need to have to do 4 different ones. If it's one for this program and there's one for another program, why can't they be streamlined? I'm just putting that out there, kind of like pinning it on a board for thought. Thank you for answering my questions.
All right. Thank you.
Albert, if I can just ask one as well. Drug manufacturers, some of those have, in fact, most of them have a patient assistance program for these folks that are indigent and they cannot afford the medication. But what I've seen, and tell me if I'm wrong, from a pharmacy side, whenever patients show up, is you don't have the flexibility, if you will, because they will send you that drug sometimes by mail to the doctor's office and then the patient goes back and gets it. But then if you change the medication midstream, you're stuck with all those drugs, syringes, Medicaid, whatever it is that they've sent you. And there's just nothing you can do with it. So wouldn't you agree that having a pharmacy that you can get as much as a 3-month supply, whatever that is, on a periodic basis that's local that somebody can get to is much better than having something directly mailed to them for a large quantity of medication for all sorts of reasons? Might be better for patient health care?
I agree. We do have a patient assistance program. We give away last year about $3 million in free drugs. It was more because it started, the type of drugs they have in the program has been going down, but we do have that directly with the manufacturer. We do have them pick it up. So we have individuals that can speak to them, and we have PharmDs to make sure they're taking the meds and then they're compliant with it for that program. But it could be 3 months, so it won't be an abuse, because if you continue sending to someone home, you don't know what may be happening. So we require them to come in at 90 days every time, so they just don't be totally maintenance, unless a provider knows it's just a maintenance drug, which they just can't market.
And I guess where I was going is, let's just say that you had a drug that was just sent to them, a patient assistance drug, but they needed to change it. If you had a contracted pharmacy that might be in a remote location, that patient could then go pick it up from that local pharmacy without.
Oh, definitely. That would definitely work. That would make more sense, because that contract pharmacy would be in contact with our pharmacists, and with our providers, and then we have some oversight.
Chairman Pierce?
Excuse me, Albert, I want to thank you and your other FQHC folks that are here and you're across the state. What you're doing to help an initiative that the House, especially Speaker Burns and this group here, have been working on, is training our workforce in healthcare, our future doctors, our future nurses, and this sort of thing. And by, having them rotate through your facility, the medical students as well as the residents, they see what you're doing, and you're helping to train those future people who are going to be out taking care of folks in this state. And we need to keep you viable so y'all can continue to practice this and help us educate this workforce that we need out there. So thank you for that.
Well, thank you. I didn't mention that. I know many of us, we have the students, the residents, we have the people at Augusta Dental School, we have pharmacists, we have behavioral health. They all rotate through Curtis Cooper with our providers as well. Thank you.
Nicole Roebuck.
Chairman Stevens, members of the committee, thank you so much for this opportunity to speak on behalf of my organization, Aid Atlanta. My name is Nicole Roebuck. I'm the executive director of Aid Atlanta. We're the oldest HIV/AIDS service organization in Georgia. We've served Georgians living with and affected by HIV and AIDS since 1982. And in 2015, we became an affiliate organization of the AIDS Healthcare Foundation. And that was in order for us to expand our services and reach to those people living with HIV and AIDS. My colleague, Jeremy Zellers, will follow me and take you to the pharmacy counter. But I want to start one step before that with what the 340B program actually pays for and what's at stake for the people who depend on it in our organization. So as Aid Atlanta is a Ryan White funded provider of HIV care and support services. As a 340B covered entity, we are able to utilize savings from the 340B program to stretch our limited resources in order to assist even more people with comprehensive HIV care and support services. A number of those folk, a large number, are actually people who have low incomes and or no insurance at all. The people we serve are largely, like I said, low income. For many of them, especially in our LaGrange location, we are the only option for free or low-cost comprehensive HIV care and support. Actually, Representative Buckner, Meriwether, and Troop falls in our district. Last year, we served about 2,036 HIV-positive patients and members, providing clinical care, case management, housing, medication access, behavioral health, and other wraparound services. In partnership with HF's Wellness Clinic, we performed more than 15,000 HIV tests and screenings and 50,000 STI screens. We also assisted in referring and providing PrEP counseling, referrals, and treatment to roughly 2,200 people, a substantial increase over the year before. And we secured 92 units of affordable housing for people living with HIV in our community. Amongst patients in our healthcare center in Noonan, 90% of those people are virally suppressed. And what that means is they're doing very well in terms of their clinical outcomes. Statewide, that figure is 63%. So clearly what we're doing as a Ryan White provider, safety net provider, is working. And we're providing those wraparound services. You've heard several people talk about the wraparound support services that are necessary for the population of people that we see who are resource poor. There aren't many resources that they have access to. However, medication is only part of what it takes to keep somebody healthy. And what happens around that medication matters as well. So that's where 340B comes in for us. It isn't a state grant. It's not a line item on your budget. Manufacturers provide discounted medications to eligible safety net providers like Aid Atlanta, like AHF. And the revenue that comes from those savings help support the services that traditional grant reimbursement revenue just does not cover. There's not enough grant funds to cover all of the needs of the people that we see. In practice, 340B revenue helps to fund the case manager who provides comprehensive resources so that those patients we serve can have the best shot at living and thriving with an HIV diagnosis. 340B helps us to provide transportation to an appointment for someone without a car or who lives in an area where there's no public transportation. For example, in 2025, our HCC in Noonan, Healthcare Center in Noonan, which is again located in LaGrange, the 12th County Public Health District, but we are in Coweta County. The clinic is in Coweta. And we spent $103,000 in just transportation costs. 20,000 of those dollars came from the grants, came from Ryan White type grants. The remaining $80,000 was covered by our 340B revenue. It also helps us to provide those stopgap medications for patients while they work to apply for what's called the state ADAP program, which helps them to not have to pay for their medications. And that helps them to get access to those life-saving medications pretty immediately. There's no billing code to bill for calling a patient who missed a refill, nor for transportation. We can't bill that to any insurance company, anyone, nor for housing services. 340B helps make provision of those services financially possible, which is why the program matters to the people we serve. I want to tell you about Sharon, and of course Sharon isn't her real name, our patient who lives in Butts County. She's a 54-year-old woman living with HIV. She had been very sick when she first came to our clinic. She had several comorbidities and had lots of medication needs. She lost her job and her insurance due to her illness. Thankfully, we were able to provide her with several medications that are not on the state ADAP formulary to help her treat her other conditions, aside from HIV. Then after months of patching together her only means of transportation, her car finally just broke down. And she no longer had transportation to travel the 54 miles from Butts County to Coweta County, where our clinic is. Uber Health doesn't go there. Doesn't travel that far. So we have to use a medical transportation agency. And it's much more expensive. So that round trip cost can cost upwards of $250. And like I said, $20,000 from our grants is the only funding we have for that. So 340B helps with this situation. So we don't have to worry about how we can get her to and from her quarterly appointments due to 340B. And we have the funds to provide that safety net service to her. We can provide her with the medication she needs, housing support if she needs, case management services, behavioral health services. All of these things can help to exacerbate an HIV condition. So we want to provide those wraparound services. Simply but importantly, 340B allows us the flexibility to address those needs of our patients when we just don't have enough grant funds to cover. Patients like Sharon, who have no income, have no insurance, or are underinsured. I also want to speak to why contract pharmacies matter. There's one part of this I want to emphasize, and it concerns providers that aren't necessarily us. And what I mean by that is at our Noonan Healthcare Center, we actually have the AIDS Healthcare Foundation pharmacy. So our patients can access, and they would be considered, I would assume, one of those independent type pharmacies that our patients can walk down the hallway after their appointment with their doctor and get their medications. But I'm talking about those safety net providers that don't have a pharmacy in their building. A Ryan-White clinic in a smaller county may have the medical team, the case managers, the relationship with the patient, but no pharmacy of its own. And what it has is a registered arrangement with a community pharmacy, which you've heard a lot about today. And that may be how its patients get its 340B medications. When a manufacturer decides it won't honor the 340B price through that arrangement, the clinic doesn't simply lose a better price on a drug. It loses access to the 340B price through the pharmacy arrangement it uses to reach those patients, which reduces the resources available to support the services I just described. For providers in communities with fewer pharmacy options, that can be especially consequential. We're not asking Georgia to expand the federal program. We know Congress decides that. We're asking the state to protect the ability of safety net providers to use a lawful pharmacy arrangement to reach patients they already serve. The General Assembly considered that in House Bill 139 last session. The bill didn't pass, but the problem didn't go away. The patient is the test. More than 1 in 3 Georgians living with HIV was not virally suppressed in 2023. The same year, Georgia recorded the highest rate of new diagnoses of any state. Those are the people we're trying to reach, and reaching them isn't a matter of writing a prescription only. It's getting someone tested, linked to care, kept in care, and kept on treatment month after month. So when this committee weighs any of these policies, the question I'd offer is a simple one. Does it make it easier or harder for a person living with HIV to get their medication and stay connected to care? These aren't only disputes between manufacturers, PBMs, and pharmacies. Every one of them ends with a patient who either received their medication or not. Chairman, Georgia has led on these issues before, and we think there's a clear path to leading again in 2027. Thank you for having Aid Atlanta and HF here today. I'll turn it over to Jeremy to take you to the pharmacy counter and tell you what he's seeing there, unless there are any questions for me. Thank you.
Thank you, Nicole. I don't see one from us, but I've just got just overall, let's just say a person is, and you use 92% of yours that are suppressed. If they can't get their medication and they become non-suppressed, don't you have to add pretty expensive medications to their regimen to bring them back up to suppression?
So I'll let the pharmacist talk about clinically how that works. But yes, you are correct that if they don't have access to their medications, then naturally their viral loads will increase, right? So you want to decrease viral load, the HIV viral load in a person, and not the medications are what does that, helps to do that. So if you don't have access to those medications, we have a different kind of crisis in Georgia on our hands. If people don't have access to their medications, it impacts that viral load suppression rate. Yes, it drives it down.
And one more follow-up, if I can, Nicole. If a person's not suppressed, the drug diseases that are associated with it multiply.
Actually, I don't know if this is where you're trying to get, but actually somebody who is not virally suppressed is more likely to transmit the HIV disease to somebody else if they are not suppressed. So viral suppression equals untransmittable. You may have heard, those terms. Undetectable equals untransmittable.
And they themselves become sicker.
Absolutely. And they become a burden on the healthcare system, those rural hospitals that we've been talking about, the hospitals in general, those indigent hospitals that are doing right. As a safety net provider, we want to make sure that the 340B program works in the manner that it's supposed to, and that is to serve those people who have the least access.
Thank you, Nicole.
You're welcome. Thank you.
Jeremy, you're up.
All right, good afternoon, everyone. Hopefully everyone's still awake. Long day, I'm impressed. All right, I have some remarks I'm gonna kind of read from, if hope that's okay, because they kind of align with what Nicole just talked about. So, Chairman Stevens, members of the committee, thank you for having me. I'm Jeremy Zellers, the Chief Pharmacy Officer at AIDS Healthcare Foundation. I've been a pharmacist specialized in HIV now for more than 25 years. AHF runs about 40 pharmacies across just the Southeast and Puerto Rico. 6 of them are right here in Georgia. You heard a lot about the 340B overview at the meeting you had in July. You had quite a lot more that was coming out of today's meeting, so I'll skip over most of that. And Chairman, you asked 2 things to prepare for this meeting: whether we can keep our 340B program going and where PBMs get in the way of getting medication to patients. On the first, the short answer is yes. On the second, the biggest problem is a PBM telling us we may not fill our own patient's HIV prescription. Representative Buckner, you asked in July for a ranking, and I'll give you a map for what I think they should be. 3 things would help: protect a covered entity's ability to use contract pharmacies, close the specialty gap in Georgia's anti-steering law, and put a floor under what PBMs pay pharmacies. I'll go through each one. But in Georgia, AHF operates several healthcare centers and wellness centers and 6 pharmacies, as I've talked about, and we're a 340B covered entity. Our affiliate, Aid Atlanta, which Nicole leads, has 2 locations of its own. Nicole covered that side, so I'll come back, as she said, to the pharmacy counter. I'll only add that in 2023, Georgia had the highest rate of new HIV diagnoses among the states, which makes keeping people on their medication the most important thing our pharmacists do. 340B pays for a good part of that. It supports the services nobody fully reimburses: free HIV testing, free STI testing, patients who can't pay for their care or their medications, the pharmacist who calls when somebody's late on a refill, the case manager who helps a patient keep his apartment so he can keep taking his pills. Can we keep 340B going? Yes, but 2 things matter: whether manufacturers honor the 340B price and whether our pharmacies are allowed to fill our own patients' prescriptions. On the first, you heard in July about manufacturers restricting where the 340B price is honored. Let me say why that matters beyond us. Ryan White clinics are the HIV safety net in this state, funded under a federal program to care for people who are uninsured or underinsured. A clinic without a pharmacy of its own may contract with a community pharmacy to get 340B drugs to its patients. That arrangement is exactly what manufacturers have been restricting. When a manufacturer refuses to honor the 340B price through a contract pharmacy, a clinic in South Georgia, rural Georgia, anywhere in Georgia, doesn't just lose a discount, it loses the 340B price at the pharmacy it relies on to reach its patients. Whether 340B grows or shrinks nationally is a question for Congress, but protecting a covered entity's ability to use a contract pharmacy is something Georgia can act on within its own authority and doesn't require creating new state-funded patient care program. One bill not passing doesn't make the problem go away. That's the first of 3 things I'll ask for, and it matters as much as anything else I'll say today. The other pressure is the one I see at our own counter. For an insured patient, the PBM administers her pharmacy network, sets what we get paid, decides which of her prescriptions we may fill. That shows up in 2 ways. The first and the biggest is what our pharmacists call the split fill. A patient walks up with all of her prescriptions. She has her blood pressure medicine, her diabetes medication, her HIV medication, and we run all the claims. The blood pressure claim and the diabetes go through no problem. The HIV prescription rejects, with a message that says it has to be filled at a specialty or a mail order pharmacy. In some cases, the same company deciding where her prescription can be filled owns the pharmacy that it's ultimately sent to. Now, this patient, she has 2 pharmacies. One down the hall from her doctor where they know her, where they fill part of her regimen and may not know the HIV prescription that's filled elsewhere got changed or got delayed, and the refills fall out of sync. If it's mail order, it comes in separate schedule from everything else. This is also where 340B comes back in. When we can't fill an eligible prescription, we lose the 340B savings on it, and those savings help support the services we all described a minute ago. Enough prescriptions going elsewhere and filling out at these contracted mail order pharmacies changes what the program could support. That's how 340B, that's how a PBM decision at the counter reaches our 340B program. Georgia passed the nation's first PBM anti-steering law in 2019, and your own resolution says many believe steering continues anyway. We still see claims rejected our pharmacy, and they route an HIV prescription through a separate specialty channel. The result at the counter is 2 pharmacies instead of 1. One of the interesting things, I'll ad-lib here a little bit, that I see is they also have these copay accumulator programs that are kicked in now. These copay accumulator programs are what they're using to kick these prescriptions into specialty pharmacies. And I'll explain that later if you want to know, or pull me aside later. In HIV, gaps matter quickly. A meta-analysis of 24 studies published last year in Nature Communications found a median time to detectable virus of 16 days after a treatment is stopped. Those were monitored interruptions, not ordinary refill delays, but they show that rebound can happen on the scale of days to weeks, not months. And as you mentioned, they have consequences of additional expenses, additional treatment, hospitalization, resistance, more expensive HIV drugs. The second is reimbursement. I'd ask you not to treat this as a lesser point. A pharmacy can be admitted to a network and still be reimbursed below what it costs to acquire the drug before anyone is even paid to dispense it. No pharmacy can do that for very long. When a pharmacy stops stocking a drug or leaves the network, the patient is the one who loses, because that's a pharmacy she can no longer use and a pharmacist she can no longer talk to. On paper, she has a choice. At the counter, she doesn't. An open network with no floor under it is not really an open network. So what would help? 3 things, and none of them require creating new state-funded patient care programs. First, protect a covered entity's ability to use contract pharmacies. For the clinics and the rural hospitals without a pharmacy of their own, that arrangement can be essential to getting 340B drugs to their patients, and Georgia can protect it within its own authority. Second, close the specialty gap in the steering law. Georgia already prohibits steering to an affiliated pharmacy, and the current law no longer includes the old limited distribution exception, but we still see claims rejected our pharmacy, and they route the HIV prescriptions through a separate specialty channel. Make clear that a claim rejection directing a patient to a PBM affiliated specialty pharmacy falls under the same rule when an in-network pharmacy can safely dispense the drug. Among the PBM problems, this is first on our list. Third, put a floor under reimbursement. For commercial health plans subject to Georgia law, use the same NADAC-based framework and professional dispensing fee you adopted last year in House Bill 196 for the state health plans. The steering rule protects where a patient may go, but the floor decides whether the pharmacy she picks will still be there. Chairman, you spent years behind a counter, so you know what it's worth when a pharmacy knows the person on the other side of it. For our patients, that relationship helps keep them on treatment. We're asking you to keep it intact and to let the pharmacy that's already part of her care keep filling her prescriptions. 340B is part of how we sustain that care, and it works best when we keep putting the medication in her hands. Thank you, and I'm happy to take any questions you might have.
Questions? What in the world is an accumulated copay?
Oh, copay accumulators. Copay accumulators and copay maximizers go hand in hand. So these are new tricks of PBMs and insurance plans where copay accumulators are when they want to keep track of what copay was not paid by the patient themselves. what was paid by a manufacturer copay card, what was paid by some sort of third party, and then they subtract that from the patient's eligible expenses to bring down their own deductible. That means that the insurance plan gets to extract more patients from the patient and not have the manufacturer's copay card kick that in. Copay maximizers are when the next level of that, the next evolution of that, is when they've realized, okay, well, this particular manufacturer is going to offer $10,000, let's just make it easy, $12,000 worth of coverage for copays over the course of a year. We're going to set up our programs that patient's copay is $1,000 every month, with the expectation they're going to go after that manufacturer for the extra $1,000 that they offer to bring that back into care. And so now what insurance plans are doing is they figured out that if they add a wraparound service that says, well, if you sign up employer-sponsored insurance plan for these particular programs, and you do that, we'll offer a wraparound program, but we need the data. And only our pharmacies, luckily, say if you're a CVS, Caremark, will be able to give us that data. We can't get that from the independent pharmacy. We can't get that from everybody. So that means the original prescription now is routed back to their own pharmacies, because then they can get the data of who paid the secondary claim, so they can subtract that from the accumulation of the patient's out-of-pocket expenses. And therefore, they offer this wraparound service that says, and if you accidentally go above that, just to make sure, we'll cover it out of our own pocket, through an extra plan. And those are whole other programs that are set up. So even if you didn't steer the patient there, the fact that the data has to come from somewhere, you ultimately steered them anyway. Sorry. Maybe that was too much info. You're welcome.
Yes, ma'am. Thank you for the job you do.
Thank you.
Wow.
Thank you, Mr. Chairman. I'm glad you asked that question, because I was thinking the same thing. It's good to be here today. I'm Jonathan Marquis. I'm a pharmacist and the interim CEO for the Georgia Pharmacy Association. I'm going to give this committee, and especially this audience, some good news. I'm going to be brief. There's three things I have for us to look on behalf of GPHA for this committee to look at. And before I start, I would like to thank the General Assembly, each one of you in your own areas and all the things you do. I know each one of you, you've done a lot for healthcare in Georgia. And if we would model a lot of the things that you all did for Medicaid and the state health benefit plan, a lot of these things that have mentioned today would probably go away. There are roughly 600 independent pharmacies in Georgia. Of the 159 counties, only 6 counties don't have an independent pharmacy, and they don't have any pharmacy in those 6 counties. 25% of the counties don't have a chain pharmacy. So the independent, when we're talking about PBMs and PBM reform and reimbursement, we're not asking for profit. We're just asking for fairness. Joining me today are 2 respected leaders, and they'll take the tough questions. But GPHA President Thomas Scherer is here, and AIP Chairman Hugh Chansey is here as well. And they see all these things I'm about to talk about in their pharmacies every day and serving their communities. But number one, before I get started, and it was briefly brought up by the pharmacist before me, think of whatever business you're in. You could not survive if you had to dispense that product below your price that you bought it for. And that's really what is happening to a lot of pharmacies, chain and independent. They're given a contract that is a take it or leave it. And many of these counties, again, they're the only pharmacy. They've got to take it. They want to take care of their neighbor and the local mayor and the school board that come into their pharmacy. GPHA would like this committee and the General Assembly to look at 3 things, and I know the next speaker will get into the details on some of this. But number one, very similar to the state health benefit plan, is I'd like this committee and the General Assembly to review a NADAC plus dispensing fee model. And we want that NADAC to be, it can be the floor and the ceiling. And that's where we get into the problems. We're not going to get into details, but just passing a NADAC legislation, some PBMs will pay all the independents just at NADAC, but then they'll pay their own pharmacy or another chain pharmacy above that NADAC. So we need to have a floor and a ceiling. And the dispensing fee needs to be fair. Everything in your business has gone up. Everything in a pharmacy has gone up, from the wages they pay their technicians to the rent to utilities. 20% of an independent pharmacy's total sales is their expenses, and they've all gone up. Number two is to prohibit patient steering. And this is pretty simple. Georgia already has, in my opinion, and the next speaker was one of the reasons we passed it. We probably have one of the best, if not the best, steering law, thanks to you all for passing it quite a few years back. I think maybe 8, 9, 10 years ago. But a patient in Georgia should be able to, just like every one of you, you should be able to pick your pharmacy. You like the pharmacist, their prices are great. They provide these services that you mentioned: free delivery, bubble packing of their medications, strip packaging, and quite frankly, counseling and immunizations are so critical that these pharmacies are offering. And third and lastly, and just like the young lady said here before, we would love to work with you on any questions you have later. This is a very complex subject. So we'd love to help you. But number three is to require transparency and enforce all the bills that we have passed. You know, if you pass a law and it doesn't have any strong teeth or enforcement, it's just sort of a recommendation. So I'd like for the committee to look at that, and the General Assembly, because really employers and taxpayers deserve to know what the PBM charged the health plan, what it paid the pharmacy, and how much it kept. It's actually pretty simple. It's a complex issue, but those things are actually pretty simple. So again, thank you. It's been a great day. It's been a long day, and thank you all for staying, and thank you all for hosting the meeting here in Macon. I am a graduate of Mercer University School of Pharmacy, so thank you, Chairman Stevens and the committee.
You know, you hit two things, Jonathan. You said that we've passed the laws, transparency and steering and others, but it's kind of like a red light in New York, like the chairman said over here. It's more of a suggestion than a law. But I appreciate you coming down and presenting in front of the committee.
Thank you all so much. Thank you. Chairman, I have some, oh, there they are. Somebody's on it.
That is awesome. Now, how do I have the capability to click? Okay, very good. Mr. Chairman, committee, so good to be here today. It's been a while, right? Frankly, I think since I've been here, and last speaker, I know everybody's tired. I'm going to try to move briskly. Some of the things that I was planning on talking about, I think have already been covered, but I think this is a neat time because you all have passed some of the most significant laws in the country on PBM reform. You probably don't hear it a lot, right? You probably get the calls where it's, hey, I'm seeing the steering, or hey, I'm seeing this underwater reimbursement, or hey, there's this issue with these audits. And so I think that this is a hopefully a fun opportunity, to sort of look at how PBM practices evolve. But Georgia's done some things, some meaningful things that not only have led the nation, and I follow pharmacy policy all over the country. And, Georgia was one of the first states to pass MAC pricing, not the first, in 2015, one of the first states for pharmacy audit bill of rights, 2017, first state in the country to pass the Pharmacy Patient Protection Act. Before that, and frankly, let's even go back further. Georgia is one of the first states to license PBMs. And I know, Representative Hawkins, you were a big part of that too, right? So Georgia has led on PBM reform in so many, just so many different things. So Patient Protection Act of 2017, up to that point, there had been licensing, there had been audits, there'd been these very narrow, complicated bills. And that was the first bill in the country to come in and say, hey, PBM, you can't do A, B, C, D, and E, right? Very similar to like insurance code, unfair and deceptive trade practices. Georgia was the first to just call it out. These are bad practices, PBMs, you can't do it. Mandatory mail order, copay clawbacks, gag clauses, all of those things were in that 2017 Pharmacy Patient Protection Act. Then Chairman Mullis was a sponsor of that legislation on the Senate side, and Representative David Knight was the sponsor on the House side. And again, that was first in the country. 2019, first state in the country to pass PBM steering laws. Hadn't been considered anywhere else in the country. Don't quote me on this, probably 20, maybe even 30 states have followed suit with some form of anti-steering legislation. Then in 2020, you all came in with sweeping PBM reform that had so many firsts in that, including strengthening the steering law, and also first state in the country to require PBMs to report their reimbursements to pharmacies at 10% below the national average drug acquisition cost and 10% above the national average acquisition cost. And so I know y'all are probably familiar with NADAC, right? But it's a public index. It's administered by CMS via Myers and Stauffer, and pharmacies report what they pay for drugs into that index, right? And so on one hand, you have PBM drug pricing practices that are trade secreted, incredibly complex and incredibly opaque. And then you have NADAC, which is this market-based transparent index. And so Georgia was the first state in the country to say, hey, PBMs, if you're fluctuating above or below, you have to tell us, you have to report that. And first state in the country to this date, I think only 2 or 3 other states may have followed suit in some capacity. So Georgia actually has access to PBM commercial and state plan pricing that almost no one else in the country has access to. Georgia also passed a NADAC bill and state health benefit plan in 2025, implemented in 2026. And so we have an opportunity. Frankly, I haven't looked at this stuff, right? This is such a neat opportunity to look at the work that you all have done, because I do think actual drug prices and this transparency reporting can and should instruct good policy. Next slide, please. So look, y'all heard from the FTC. So I don't want to go over that, right? But one thing I'll say is pharmacy has been ringing the alarm bell for so long, and some of you have heard me say this before. I've got a VHS cassette that says PBMs 101 that independent pharmacists, probably some of them in this room, helped record, right? It's literally a VHS. I'm not talking DVDs, VHS. Pharmacy has been ringing the alarm bell on PBM practices for a long time. And I think because of the role that they play and the trust that they hold in their communities, I don't want to speak for this body, right? But a lot of PBM reform was passed based on sort of the experiences that pharmacists were seeing from behind the counter that impacted them and also that impacted their patients. But there wasn't a lot of data always, right? So much of it was anecdotal. And I think one of the big messages, and we'll go through these quickly, is pharmacies have been saying, look under the rocks. And every time you look under the rocks, the dirt is there, right? At the federal level. FTC, they've got a 6B study. It is an ongoing 6B study. They had an initial interim report. They had a second report. And obviously, if you just look at the first, right? How PBMs profit at the expense of patients by inflating costs and squeezing Main Street pharmacies, right? That's our independent pharmacies. That's the Georgia Academy of Independent Pharmacies pharmacies. That's American Pharmacy Cooperative, the company I work for, their pharmacies in Georgia. This is the FTC. This isn't independent pharmacies saying this. This is the Federal Trade Commission, which historically, before the 6B study, had taken a very different position on the role that PBMs and big insurers play in healthcare. They've done a 180. Next slide, please. So again, they hit this, but one thing that I want to just commend this committee for in particular is having so many patient groups testify, because this can be esoteric stuff, right? It's easy to get lost in 3.3 billion or 1.8 billion or the top line number, the big 3 PBMs, $7.3 billion of dispensing revenue in excess of NADAC at PBM owned pharmacies, right? It's like make-believe money, $7.3 billion above the national average drug acquisition cost is what the FTC found. For every single one of those dollars, a patient overpaid. A sick patient, a patient who is fighting for their life, fighting for their health, and they are overpaying by billions of dollars at PBM-owned pharmacies that they are steered to, and they don't have a choice, right? And that's not independent pharmacy talking, although again, you all led on this before it was frankly even on the FTC's radar, right? You all were tackling this in 2019. You all were tackling this in 2020. So here we are now, and the FTC is onto it, right? But you look at these, right? They're targeting the sickest patients, MS, HIV, hypertension, cancer, and they're marking these drugs up, and they're profit taking, and and it's gross, right? And I think folks are starting to recognize that. Next slide, please. So this to me is really interesting because this is another view, right? We've got the FTC view. Some of the best audits in the last several years have been done in the Federal Employee Health Benefits Plan. It's one of probably two of the largest self-funded plans in the country, right? It's operated by the Office of Personnel Management, and there's different insurers, and so there's different programs within this. But the U.S. Office of Inspector General has audited at least 4 PBM practices and 4 different plans within that. And the numbers are staggering, right? Like just, I mean, 580 million in PBM overcharges within that plan, right? Within the Federal Employee Health Benefit Plan, $580 million. And, there's about 4 audits that they really focused in on. The bulk of the money is coming from, frankly, spread pricing, right? Engaging in games from what they reimburse the pharmacy versus what they reimburse the plan. There's a lot of it in some of the audits coming from rebate dollars, some from offshore rebate aggregators, and there's a lot of it coming in the way of fees that are being applied to pharmacies. But what's really important here, and I'm sure, you all have dedicated time, committee hearings, work on this, for years and years and years, and yet the practices persist in different ways and they evolve, and it's like frustrating, right? And understandably so. What's so fascinating about this is that it's literally a situation where all of these plans were supposed to be passed through, right? They were supposed to be transparent. The plan was supposed to get the benefit of the discounts. There's supposed to be no spread pricing. And these are the numbers that we're looking at, right? And these are just 4 within the Federal Employee Health Plan. Over like 490 million in PBM overcharges difference between what they reimburse the pharmacy and what they charge the plan. Next slide, please. This is going to get a little technical, but I think it's instructive because here's the thing, right? It's like 3D chess. There's a contract. Office of Personnel Management's done a pretty good job saying no spread pricing, pass-through pricing. We get the benefit of the rebates. We get the benefit of the discounts. We get the benefit of all of these things. What you charge the pharmacy is what we pay. And so what the Office of Inspector General found is that spread pricing has evolved. And so back in 2018, and by the way, you all banned spread pricing in state plans in 2019 or 2020. I think it was 2020. You all banned spread pricing for state plans. And Georgia was also one of the first states, not the first, top 3 to uncover spread pricing. The 2018 Medicaid managed care, there's about $50 million in spread. 2019, about $40 million in spread, right? So you all got at that, via the appropriations process and ordering audits that uncover that spread. And then you acted really quickly in 2020 and said, hey, right, we're going to cut out spread. But spread has evolved. And so what happened in the old days is they'd reimburse a pharmacy 5, they'd charge the state 8, right? And they're creating that spread on that drug price. What they are doing now is something very different. And so like the FTC is working on consent orders, and like those are definitely steps forward, but they're still like operating off of traditional definitions of spread, right? You can't charge a higher price for a drug to the plan that you reimburse the pharmacy. But what they are engaging in is something called effective rate pricing. And what they're doing is they reimburse the pharmacy, but then after the fact, based on some sort of an average effective rate, they come back and they shuffle it around, and they can move money around within plans, within the same plan, or even other plans. And so it gets incredibly hard to audit. but the Office of Inspector General has done it, and he's found it. And what they have figured out is essentially when they did the audit, the PBMs provided essentially the discounts to the Office of Inspector General to review, and it looked like it matched, right? It looked like, hey, this is what they paid, and it matches what us, the federal government, paid, no problem. But the Office of Inspector General did one extra step. He said, hey, let me see your pharmacy contracts. And the Office of Inspector General has that authority, right? So everything looked like it checked out. Hey, the PBM provides, look, discounts match. Great, but I want to see the pharmacy contracts. And what the Office of Inspector General found over and over and over again in these audits is that the discounts negotiated with the pharmacy didn't match the discounts, right? So essentially it's like a classic, there's two sets of books, and how do they get away with it? They're moving it around on the back end. So it's a shell game. So even when you take the right steps, you have a pass-through contract, you prohibit spread pricing, the games go on, right? They're able to continue to manipulate that pricing. Now, that's Federal Employee Health Benefits Plan. But here's where it gets really interesting. There was a TRICARE hearing up in DC in July, and a senator got a copy of a contract and read it, and essentially it says that the PBM had the right to aggregate reimbursement, reconciliation, and offset methodology, right? Which basically means we can do whatever we want after we reimburse you. What you get reimbursed, we get to change. And she got her hands on that. And it was, I said it in the hearing, it was a smoking gun moment. But what makes it even more fascinating is there's some lawsuits popping up in states, a couple of states, Arkansas, Tennessee, have looked to essentially prohibit vertical integration between pharmacies and PBMs. And the states that pass, the PBMs are litigating that, as is their right, certainly. But they're starting to stick their neck out a little bit in those, right? Because in trying to argue against the state law in Arkansas and Tennessee, one of the PBMs comes in and says, hey, we administer our federal plans on an undivided and indivisible basis with our commercial plans. They admit it. They admit it in their own pleadings, right? Which is stunning. And that actually may have been that quote may have been in an Ohio lawsuit for antitrust, I think, violations against the PBM in that one. But anyway, it's fascinating reading some of these pleadings. But essentially what they're saying is, hey, we administer the Federal Employee Health Plan, the retail network, in the same way we do in commercial. And so, hey, if I'm a Georgia employer, right, if I'm an employer anywhere in this country and I think that I've got a pass-through contract, well, guess what? You may not have an Office of Inspector General that can get at all of that, but the games are there. Right? Again, every hood they look under, every rock they look under, it is there. And so the Office of Inspector General audits haven't gotten a ton of attention, but they should, because they're really instructive, right? Even if you think you're doing everything right and you think you have a pass-through contract and you think that there's no spread pricing, lo and behold, it is alive and well, right? And data reflects, when you see the variability in pricing in Georgia, we'll talk about a little more, it's happening here too, right? And it's happening in the commercial market, and it's happening with impunity. Next slide, please. Want to talk a little bit now about other state actions, and we won't go over all of these, but Tennessee's been robust, right? They've sort of followed Georgia's lead on certain provisions, gone a little bit further in certain ways. But what you see here is they have just been robust in terms of conducting statewide compliance audits, right? These aren't coming from pharmacy complaints, and we look at this myopically. They are looking at PBM practices across the state on a broad scale, because 9 times out of 10, if they're steering here, they're steering here, 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 and here. They're under reimbursing here, they're under reimbursing everywhere. And so what we see here in Tennessee, a neighboring state, is there has been robust enforcement actions, right? There have been consent orders. And I forgot the whole number. I think I wrote it down, but there's, so like 8, I think, in the last 2 years of these broad statewide audits that have uncovered practices that don't align with state law, for which they've entered into consent orders, right? Which is a really big deal. We'll talk about this a little bit more. I think one of the things that's different, Georgia has, frankly, the Commissioner of Insurance has some of the most robust authority of commissioners of insurance across the country in Georgia. There are some unique features, right? Like, not only can he issue fines payable to the state, he can issue fines payable to pharmacies, can issue fines or recoupment payable to pharmacies as well. has the ability to also be conducting these statewide audits. You know, one of the things that I see when I look at enforcement across the country, and I'll be frank, right? I think Georgia's laws, for the most part, are amongst the top of the nation, right? Let's call it, you know, other than maybe reimbursement where there's some work to do, let's call it B+, A-. Enforcement, you know, a D is generous, right? A D is generous, and I'll just say it. But Tennessee has a pharmacist and a lawyer, at least one lawyer, right, who their job every day is to go into work and enforce those PBM laws. They go in and that's what they do, right? And there's like, I don't want to lay blame here because like obviously there's massive, you know, there's all sorts of things to consider, right? Are pharmacists filing enough complaints? Have pharmacists got exhausted and they lost by fatigue? There are legitimate, you know, legal angles and issues depending on the issue that you're trying to get at. But what we see is states that have that, and next slide, please, but states where they do in fact have staff, dedicated staff to enforce the PBM laws on the books are having much more success enforcing those laws. And again, like I think the code builds out some robust authority for the commissioner, but I do think there are some tweaks that could be at least considered that would help ensure that Georgia not only leads on the statutory front, but leads on the enforcement front as well. And, you know, a lot of our neighbors sort of touching, Florida is going to be introducing some things, I think, in the next week that are really exciting on the enforcement front. A lot of states in the Southeast have, you know, starting to catch up statutorily, but really leading the fight on the enforcement front. Next slide, please. So we'll go through this quickly, but, you know, you look at the OIG audits, there it is. You know, you look at the FTC, there it is. There's also some private companies and you know, some private studies and reports that have come out. We've worked on a few, Through Access have worked on a few. This was one of my favorite ones. It's looking a little old, but NADAC decreased by about 9%. And the largest prescription drug plan in Part D over that same period increased their drug prices on seniors by 51%, right? So, you know, PBMs love to say, we don't set drug prices. Well, here you go, right? Generic drugs were deflating. PBMs setting drug prices at the counter were inflating by as much as 51%. So it really, and that's one plan, right? But so for context, the same study looked at, well, hey, you know, if we looked at just moving to a NADAC model, how much would have that saved over that period? And it came out to about $18 billion in savings. There was a MedPAC study that found that there were, I know y'all have heard about DIR fees, right? It's a Medicare issue. It's not something the state necessarily touches, right? But a MedPAC study found, I think, don't quote me, I think it was plan year 2021, there was about $12 billion in DIR fees in Part D. And so what that means is they charge patients $12 billion more at the pharmacy counter and then took that $12 billion back from pharmacies. It's the federal government's data, right? What you heard from pharmacists is they're killing me. They're taking back this money a year later, but there wasn't data. It was esoteric. Pharmacists knew it was happening, but prove it, right? It's really hard. It's really hard. Well, MedPAC looked at it and it was $12 billion. And these are America's seniors, right? A lot of them sick, a lot of them on multiple medications. There are replete studies out there that show that the higher prices at the counter lead to medication non-adherence, lead to poor outcomes. And so the pharmacy benefit managers, federal government contractors or subcontractors, employed a strategy to overcharge patients $12 billion and then take it back from pharmacies after the fact. Next slide, please. This one I think we'll come back to this conceptually, but this one's fascinating, right? And so, you know, they looked at drug claims over a period of a year, and they looked at drugs where there was no NADAC change, right? So NADAC was the same for the whole year, same dang price all year long. And you've got like meloxicam with like 117 different price points. You know, another one with 41 price points, right? Like, so these PBMs are reimbursing pharmacies at 118 different price points for a drug where there's been no change to national average drug acquisition costs, right? Again, proof positive that PBMs are the ones setting drug prices and PBMs are the ones manipulating drug prices. Harken back to those OIG audits, even when you think you do everything right, if you leave the pen in their hand, they will find a way to win. That's what we know. Ban spread pricing, require pass-through contracts. This is what you get. Next slide, please. Now here to me is just stunning is if you look at not only there's these different price points, but what's the range of the price points, right? Are we talking $1? Right? Hey, there's 100, one's $1.01, one's $1.02, one's $1.03, one's right. Like, no, like massive. So meloxicam, the lowest reimbursement was 79 cents. The highest was $200. And I'm willing to bet you this, the $200 one wasn't filled at an independent pharmacy, right? I'm willing to bet it probably wasn't filled at a non-affiliated chain pharmacy or a grocery pharmacy either, right? Because their trend that the FTC finds, that a lot of the estate's audit finds is over and over again, oops, oh my God, vertical integration, which was supposed to create efficiencies, which was supposed to lower costs. Oops, here we go. We paid ourselves more. Must have been an accident, right? Must have been an accident. Next slide, please. But I think that speaks to the range. Now, this one to me is really particularly funny. This is the same pharmacy. It is the same drug. It is the same day. It is the same pharmacy benefit manager, right? So once again, same day, pharmacist behind the counter, processing claims. They get a prescription, they run it through. The point of sale software gives back the PBM price. So 5 different price points for the same drug at the same day, ranging from $9 to $96 by the same PBM. Inexplicable, right? Like there's literally no rational explanation other than depending on what their contract is with who. One may be a spread pricing contract, right? Where they get to reimburse the pharmacy low and the other high. The other one may be a little bit different, right? But they are the ones that are setting these prices. And again, like that one to me is one of my favorites. It's a myopic look. And as we go through this, and I'll pick up the pace,
Greg,
but we're going to look at some, yes, sir.
you're painting a picture. How do we stop it? I mean, I'm sure that might be a slide down. I think we got the picture.
You got the picture. Very good. Okay, next slide. I was going to go over this all one more time before I got to that. Like I like to say everything twice. Well, let's skip. But this one is interesting. Okay, stay right there for 1 second. So this one, not only were they looking at point of sale pharmacy data, but they got the employer data. And what they found is as pharmacy reimbursement at retail independent pharmacies decreased by 3%, what you see is the plan sponsor, the employer costs increased by 30%. Some of that is absolutely explained by traditional spread pricing. Next slide. The other is they pay themselves more, right? So if you look at the mean margin at mail compared to the mean margin at chain, at grocer, at small indie versus affiliated mail order, the margin is stunning, right? And so that also explains why, you see, sure, independent pharmacies prices may be going down, but they're not getting the cherry-picked drugs, right? Those patients are being steered out of their pharmacy and put in here. And that's the difference in margin. And again, I think stunning. Next slide. Within that same study, and you saw this with the FTC reports as well, but they're picking these generic drugs that they call specialty, targeting the 6 patients and massively marking those pharmacies up. If you look at this one, the one funny thing is observed retail pharmacy claim, one of them for one drug, check the box. All the others, none of them were observed in any of the retail pharmacies that were looked at, which means those were being filled at the mail order pharmacies, which are disproportionately PBM owned. Next slide, please. Very, very quickly on this, federal employee health plan, very basic. Patients get to fill 2 prescriptions at a retail pharmacy, then they have to use the mail. And for specialty, they have to use the PBM affiliated pharmacy. 2 fills for generics, and then have to use the PBM pharmacy as well. So what we found, and you guys remember this from Georgia in 2024, PBM say, you cherry picked. You picked 15 claims, right? That's what we had on that one pager. 15 claims, that's not the whole universe. We took the top 100 most dispensed drugs. We looked at it 79 out of 100 times. The PBM required mail order pharmacy was more expensive even for these generics, right? Which, obviously busts the myth that PBM mail order pharmacy is cheaper. This is the top 100 most dispensed generic drugs, period. Next slide. Of that, like 34 out of the 100 were more than 100% more expensive than the independent pharmacy. And then if you look over here, again, same players, right? Look at the teriflunomide, it's a MS drug, and you got a 3,000% markup there. Next slide. So this is just a little trip down memory lane, because this is going to instruct, I think, Representative Hatchett, hopefully the answer to your question, right? Which is let's cut to the quick of this. But y'all remember this in 2024, right? It blew up. The most stunning example was like the independent pharmacy that went out of business that month was being reimbursed. I think it was $1.92 for atorvastatin, and another pharmacy was being reimbursed up the road $89 for that same drug, right? System broken, and this kind of blew everything up. Next slide. You all entered into this a little bit last year as well, right? But obviously there were efforts to move to a NADAC-based system. And in 2024, when we saw that, obviously there was a piece of legislation that looked to address it, right? Hey, let's move to an ADAC-based, let's take away the ability to set these arbitrary drug prices. And CVS, who is a state health PBM, ran their numbers. They looked at 2023 claims, and they came back and they said, hey, it's going to cost $17 million to the state to move to NADAC. Right? It may save money on ingredient costs, but it adds the dispensing fee. You all heard that last year, right? If you add a dispensing fee to every claim, it has to cost money. Next slide, please. Here's the thing. You all did the math, right? You introduced the legislation. I believe it was Representative Kelly carried the legislation, and they actually did a claims repricing. And a crazy thing happened. Lo and behold, it said it would save $11 million, right? So there's a $30 million variance there between what they said it was going to cost the state based on 2023 claims and what the math actually showed. Now, I want to be full disclosure. So, the PBMs did say, hey, the PBM said there's going to be these extra regulatory costs and all of these things. So I included that there. But the claims, when you run what their prices were in state health benefit plan, and then you compare it to NADAC showed 11 million savings. Not stunning savings, right? Like for a statewide plan, but material. And on top of it, it took away the variability. It took away the manipulation. It took away their ability to overcharge the state at the pharmacies that they own. I'd also note in the footnote here, they said, hey, a lot of these so-called fees are going to be, coming whether we move to NADAC or not. Next slide. So, state health benefit plan passed 2025, independent pharmacies, NADAC plus 1150, chains, NADAC plus 1040, should say 1050. Jonathan Marquez, GPHA CEO, noted floor and ceiling. There's been a lot of NADAC legislation all over the country. A lot of them do it as a floor, which is, hey, you can't reimburse a pharmacy below X, right? Great, it's going to help keep pharmacies in business, but it doesn't prohibit the gains. It doesn't end PBMs marking up hundreds of percent, thousands of percent. Highest I saw looking at federal employee health data was a 47,000% markup over NADAC on an MS drug. 47,000% over NADAC. So this is in effect, and this gives us a really neat opportunity to kind of look at what it looked like then, what it looked like now. We'll look at a little Georgia data. We're done, I promise. Next slide. So, then 15 commonly prescribed drugs, 1 Georgia independent, 3 nearby chains, 57 different price points. And I want to point to the atorvastatin because that was the $1.90 to the $89.98. So same PBM, same plan, state health benefit plan, same drug, same quantity. If a state employee went into the independent, they're paying $1.90. If they walked into the chain, $89, right? That was the world we were living in then. Next slide, please. So today, I just polled because we were coming here. So I polled this yesterday. Macon Independent Pharmacy. I picked it randomly. I don't even know it, which bothers me because I think I know all the independents, and picked the same 3 chains. And guess what we have? An 8% variance. There's 2 price points. And it's because of the difference in dispensing fee. So if you're a state employee today and you get atorvastatin, you walk in, you're going to pay $11.33 to $12.33, right? Like, so you've removed that variability experience for the patient, the state employee. At the same time, you're ensuring that one pharmacy isn't able to grossly profit take that may or may not be affiliated with the PBM that it's administering the plan. and sustainability for retail pharmacies that aren't affiliated, whether those be independents, whether those be chains, whether those be grocers. It's the same experience. And again, by comparison, $1.92 to $89, right? So like that's the difference we're looking at. Next slide, please. And again, these are myopic. This one, I think, again, teriflunomide, I'm going blind as I'm getting old here, but this was, again, 2024, 10,600% markup on teriflunomide, right? Quotes, generic specialty drug that patients are disproportionately having to fill at the PBM-owned pharmacy. And now today, or yesterday, this was the price for that drug moving to NADAC, right? $18.75. CVS's price in 2024, 10,600% over NADAC. And so to answer your question, taking away the ability for PBMs to set prices removes those gross markups, increases transparency, aligns with the market, and from my perspective, when you look at that, it's not even close. So these are myopic examples, but again, when they did the math across all 2023 claims, there was that roughly $11 million in savings too. And how do you get $11 million? If you're adding a dispensing fee to every claim, because that's what PBMs say, if you add a dispensing fee to every claim, you just take the number of claims, you multiply it times the dispensing fee, and oh my God, this is going to cost millions and millions of dollars. But what they don't tell employers, what they don't tell you, is that it's also stopping these 10,600% markups. And that is how the math works. Next slide, please. So we'll move quickly here, but this is, I don't think this has really been leveraged or looked at. 2020, Georgia, first state in the country to require PBMs to report their drug prices in Georgia, 10% above NADAC, 10% below NADAC. And so if you look at this window, and 2024 claims weren't complete, 2021 claims were incomplete because of when the reporting started. And you're getting a fully insured market and state plans, but there was just an ingredient cost, $242 million above NADAC, right? This is Georgia data, pharmacies being reimbursed in Georgia, $242 million. So if you just move to NADAC out of the gate without the plus, and you look at that, there's $242 million in savings. But if you add in the self-funded market, which is not getting reported, I mean, incredibly conservatively, you're looking at $400 million there, right? And moving to NADAC just lowers those ingredient costs. And again, it ends those sort of gross markup charges. Next slide, please. So here we go. Georgia prices, 2025, these are generic specialties that they call specialty, right? There's nothing special about them other than they treat really, really sick patients, but they don't require special handling, things like that. And so I'm going to go back to, I can't control the slide deck. I'm not going to ask him to back up, but remember a few slides ago where we solved that teriflunomide problem in the state health benefit plan, right? You look down there, teriflunomide, CVS, January 2025, $5,400 for that drug. NADAC's under 20. PBM's own data, right? This isn't coming from an independent pharmacy counter. This is coming from reporting that they're required to report because of the work that you all did. But I think it's so poetic to look at what CVS was charging in state health benefit plan in 2024, what they're charging now that they have to do NADAC plus dispensing fee in state health benefit plan. And then you look at this in the commercial market at $5,400, my God, right? 23,000% above. Next slide, please. HIV, right? And you all heard from some folks here representing patients on behalf of HIV. And, one of the things the FTC said is HIV was one of the drugs that was most targeted. And so looked at 2025 data and, there you go, right? Hundreds to thousands of percent above NADAC on these life-saving drugs, treating this serious condition. And it is happening in Georgia. 2025 is our most sort of complete year of data. So you don't see 2026. But I can tell you that we're seeing the same patterns in 2026 that there were in 2025, right? When PBMs are allowed to set prices, this is what you get. And under no circumstances can a PBM ever argue that this is saving money. And again, kudos to you all for hearing from the patients, because it can get esoteric looking at percentages. It can get esoteric looking at large numbers, but these are drugs that patients are having to pay for, that the state is having to pay for, that employers are having to pay for. Next slide, please. This one, just again, a narrow look into Georgia data, but what we see here, again, 2025, the non-affiliate reimbursed 40% below NADAC, the PBM affiliate reimbursed 88% above NADAC, right? They're there. This isn't every claim, right? There, you can look at thousands of claims and everything looks normal. You kind of have to know where to look, what drugs to look, because if you look over a book, it can get hard to identify. So I think it is instructive to look at individual claims, but by no means do I want to give you the impression that this is happening on every claim, because it's not, right? But it's happening. Own data, and the only reason we're getting this unprecedented glimpse into their pricing is because of the law that was passed. Next slide, please. So this one is looking at a little bit of a more aggregate view, a broader view. We took 2025 and we basically aggregated, hey, PBM, what the big three PBMs reimbursed themselves based on the basket of generics that were dispensed in the Georgia data. And then we looked at the lowest dollar amount for each of those drugs that was dispensed to non-affiliate pharmacies. And what you get is I think really pretty stunning, right? The percentage increase from what they were reimbursing at the lowest point to a non-affiliate versus what they're reimbursing themselves, 600% in the aggregate, 487% in the aggregate, 180% in the aggregate. So this myth that hey, pharmacies cherry picking, right? They're looking at one or two drugs. The aggregate data reinforces the same story, right? They're picking their winners and losers, particularly the generic specialty. They're massively over reimbursing themselves, but also in the aggregate, when you look at the basket of generics that were filled, you see the same thing, right? So we look close, we look broad, it largely tells the same story. The beautiful part is it's their data, right? It's what they're reporting. It's what they're required to report under Georgia law. Next slide, please. Atorvastatin. Again, you've heard me talk about this one a lot, but so there were basically two different NADAC prices over the course of the year for 2025 for these atorvastatin 20 milligram. And so while there were two NADAC prices, what we see here is one PBM had 123 different prices, one PBM had 81 different prices, one PBM had 84 different prices. The lowest reimbursement, and I'll explain this if you want, but the lowest reimbursement was a pharmacy dispensed 30 days worth of atorvastatin and they owed 30 cents. They not only didn't get paid, they had to pay out of pocket 30 cents. This is their own data. If y'all want, I can show you the actual specific claim that they reported. Happy to email that over to you. The other one, the lowest reimbursement was zero. So a non-affiliate pharmacy filled a $30 prescription for atorvastatin and they were paid a total of nothing. So same drug, relative same NADAC price. There were two NADAC prices. They were within a cent of each other. But yet here we are, 120 price points. The lowest pharmacy was reimbursed was zero. The highest a pharmacy was reimbursed was $1.41. NADAC was $12.70. NADAC reflects the market. NADAC is sane. It is sanity, right? And it is transparency. That's NADAC plus $11.50 dispensing fee. But again, right, like these massive, massive swings under the PBM's own data. Next slide, please. So this cuts to the quick, right? But Georgia has led in so many different ways, but what they did in the state health benefit plan and the university system, what you all did on that bill, cut out the variability, cut out the markups, brought sanity to the market, and it's something that can be applied in other channels as well, right? Now, full disclosure, right? Not an easy fight, because what are PBMs going to say? They're going to say the same thing to their employers that they said to you when you passed steering in 2019 and 2020. Do y'all remember, like, they were passing things around saying it was going to be, I'm going to mess it up now, but it was like the steering law was going to cost Georgia $8 billion. You remember that, right? Like $8 billion, right? The sky is falling. Oh my God, the world is ending. the funny thing is insurers don't come down to the Capitol when they raise their premiums year over year over year. They're not worried about telling you that then. But when there's a legislation that's going to cut their profits, all of a sudden they're real concerned about talking to you about premiums, right? But that said, employers are not drug pricing experts, and Georgia has a lot of big employers. And so, again, the state's done it for the state health benefit plan. They've done it for the university system. The state's done the math. The state's done the work. And you've got Georgia public reporting that backs it up. Still doesn't mean it's going to be easy, right? Because again, they will scare employers. They will say it will raise costs. They will say it will raise premiums. But the solution from my perspective is obvious, right? We've seen spread pricing prohibitions. We've seen transparent contracts. We've seen pass-through contracts. All of those things have failed. You have to take the pen out of the PBM's hands. And that's what NADAC does. It aligns to the market. NADAC isn't perfect, right? It's voluntary reporting. It doesn't necessarily reflect all discounts. It's disproportionately reporting by independent pharmacies. So NADAC can be improved. That's not something that would happen at the state level. There are bills that are looking to do that at the federal level. But NADAC is still by far and away, the most comprehensive, transparent, robust drug pricing index that there is, and it doesn't rely on PBM trade secrets. Next slide. Very, very quickly, right? Vertical integration. I think it's something that absolutely is fair game to consider. I think a lot of state legislators feel as though, hey, we've tried to stop patient steering. They ignore it in the self-funded market. Well, we've tried to stop these pricing disparities with MAC pricing laws, other things. They continue to do what they do. And because they are vertically integrated, they've proven again and again, right, that they're going to find ways to evade laws. They're going to develop processes. Spread is no longer at a drug basis. It's now created in aggregate across plans. It gets harder and harder. Hey, let's basically say you can't be both. You can't have that inherent conflict of interest. 2 states have done it. They've resulted in lawsuits in both states. I think it'll be interesting, right? We'll see where it goes. Their argument essentially is some preemption arguments for like TRICARE, but broadly, I think the core of their argument is, hey, this violates the Dormant Commerce Clause. You can't favor in-state businesses over out-of-state businesses. But this doesn't target what state a business is in. It doesn't target what state a pharmacy is in. It doesn't target what state a PBM is in. It targets vertical integration, which again, as you all heard from the FTC, proves to be sort of the secret sauce for how they're able to manipulate so many things that they are. That said, that can pass next year. That doesn't mean PBMs still can't under-reimburse pharmacies. It still doesn't mean PBMs can't manipulate pharmacies. So I'm a big fan of taking the pen out of their hand. Next slide, please. So I'm going to start, obviously already hit NADAC Plus. I think a vertical integration is fair game to look at, right? I don't think it's an easy fight. I think there's implications there. In certain ways, I don't know that they go far enough, right? Because we know that PBMs aren't just vertically integrated with pharmacies. They're vertically integrated with insurers. They're vertically integrated with offshore GPOs, some of them outside of this country, where they aggregate rebates and they charge admin fees and they charge service fees and they hide rebates via a variety of different ways. They're also starting to get into the private label business. So they have their own generic medication that they are reimbursing far higher than, right? So there's all sorts of vertical integration. I don't think that's easy. I think it's worthy of consideration. I think, the states that have done it, Arkansas, Tennessee, again, obviously, obviously we'll see how that plays out in court, but sure is worth considering. And if I was betting on a state that could do it, right? Again, Georgia has led over and over and over again, but that doesn't take care of sort of the reimbursement problem. So again, I'm a fan of NADAC. Some states have done it just for independent pharmacies. Some states have done it on the floor. I believe it should be across the board. If you're a PBM and it's, hey, you have to reimburse only independents at NADAC Plus, you're laughing on your way home that day. Why? Because you still get to pay yourself more. Nothing changes. They'll pass those costs on, whether it's to the client, right? Like, so if it's a floor only, you're not bringing prices down, you're only bringing prices up, and then they get to continue to gorge and feed on the prescription drugs that they want to gorge and that they want to feed on. So again, big proponent of NADAC Plus as a floor and a ceiling. And for folks who say, hey, this is like pharmacy, trying to write a check, how many folks who are like looking to bank something go in and ask for a ceiling? Because basically that's what pharmacy's asking. Cap what you can pay us. Make it fair, make it transparent. But if you're price taking, you're not asking for a ceiling there, right? You're simply not. Enforcement, again, I think it's absolutely worth consideration of, I would say, if you look at Tennessee, I would argue the Georgia Commission of Insurance has more robust authority, but it does say like there may conduct compliance audits. Tennessee's is shall conduct compliance audits. And I think you see the difference there. I also think, and there are some states where it hasn't been explicitly funded. Alabama passed a law 2 years ago. That Commission of Insurance has been amazing, right? They've hired a pharmacist. They've now hired 2 attorneys. That wasn't a statutory mandate, right? But they took it seriously and they're bringing on a team. And so I think, I think it's worth considering an appropriations for those positions. It's worth considering that being a requirement. But when you have a pharmacist, you have an attorney, and their jobs are to go to work every day and make sure that PBMs are adhering to the law, I think the PBMs are going to take Georgia a lot more seriously if that happens. I think there's other things that could be considered, right? Maybe some sort of dual oversight with Attorney General as well, I think could be worth considering also. But again, right, I'm looking at bills or laws all over the country in many, other than the NADAC reimbursement, everywhere other than that, and even state health plan, Georgia's led there, right? Georgia's code looks fantastic, right? It could be updated in a few things, maybe addressing the effective rate a little more explicitly. But, if I were picking objectively, I think making sure that you get that enforcement angle right is going to help ensure that all that amazing work that you all already did bears fruit. And so happy to answer any questions. I will leave also with this, because we are here at Mercer. I don't know if she's in the room or not, but Dean Sumner in 2020 came to a big PBM hearing and gave some of the best testimony on pharmacy benefit managers. And that was very much a catalyst to that year, which again led to the strong steering laws and also led to the mandatory NADAC reporting. And there's going to be more to come. We're going to be doing more work and we'll keep you all updated on that. But the work that you have done has borne fruit, and it will instruct, hopefully, policy here in Georgia. But I think also it will instruct policy across the country. So happy to answer any questions and grateful for all of your time.
Hit it all, Greg. Tell us exactly, you live in DC now.
All around, yeah. Yeah, I mean, we're working in, a variety of different states, looking at policy as well as DC. And I would say there's been, so that we talked about those federal employee health benefit plan audits. The federal employee health benefit plan is essentially falls under the oversight committee in US Congress. And so there is a bill, Pharmacists Fight Back Act. It's HR 6610, and it looks to move to NADAC plus, as well as curb some of these effective rate pricing, pharmacy fees, et cetera. And it's co-led, it's Chairman Comer, who's the chairman of oversight, who's done massive amount of work on PBMs. So he's a co-lead of this bill. Representative Auchincloss is the bill sponsor, Democrat out of Massachusetts. And that bill was marked up and moved out of the oversight committee in July. So that we think is certainly a really big deal. And that's looking to essentially bring the solutions we're talking about here today to the federal employee health benefit plan after those audits found just sort of all of those same egregious problems.
Short of eliminating the vertical integration that some of our other states have taken, is there any thinking along the line of making these entities, whatever they are, this conglomerate, a fiduciary?
They don't like it, right? Like, I think that there is, and that's also, there is a piece of legislation at the federal level that looks to make PBMs fiduciaries in the employer market. And I think absolutely a policy worthy of consideration.
Could that bring them under RICO? I think I put in a bill before.
Someone dropped a bill about that, as I recall, this chair.
Thank you, Greg. Appreciate you coming. That was incredibly informative. Thank you for saving state merit teachers and others tons of money on their health insurance plan through the NADAC pricing policy and saving our budget some money, along with saving some of our pharmacies.
You all did it and you acted quickly. And I think the data tells the tale. So thank you, Mr. Chairman. Thank you, committee.
Thank you, Craig. Good job. Onward. Ladies and gentlemen, that is the last of our named presenters. We've got some others. Is Harrison Hems here or Trent England that wanted to address on a short basis?
Certainly. Thank you, Mr. Chairman Stevens, members of the committee. I will be very brief. My name is Trent England. I'm the founder and executive director of Save Our States and Save Our States Action. We work on state-level public policy nationwide, based in Oklahoma City. The most basic fact about 340B is that it's a price-fixing program that today mostly generates windfall profits for giant tax-exempt hospital corporations. The common origin story given for 340B misses two important points. First, it was Congress's attempt to fix a problem that Congress had created in the first place. And this is worth understanding. Congress stepped in 1990 to try to fix drug prices and bring them down. And actually, for some of the kinds of providers that you've heard from this afternoon, actually had the effect of pushing prices up, because drug manufacturers, without government intervention, had already created programs to push down costs, essentially for patients who couldn't pay, right? To try to make sure that their drugs were reaching those patients without government intervention. Sometimes we forget in conversations like this that things can happen without government intervention. But Congress stepped in, they tried to fix these prices, they caused some of the prices to go up, so they came back in 1992 with 340B as a way to try to really get back to the kind of price, the kind of price discrimination, lowering prices that had already existed in the marketplace. And again, this is pre-Medicaid expansion, this is pre-Obamacare subsidies. Obviously, this was not a program designed to generate windfall profits for anybody, or really to generate profits for anybody. It wasn't primarily a subsidy. And someone referred to this earlier. It was really making it so that clinics that were treating patients who couldn't pay, right? So there's no money being paid for those drugs. They could buy these drugs at an extremely low cost, right? Fast forward to today, obviously, in a world where a lot more people are insured, a lot more people are covered by Medicaid, we hear people just sort of openly talking about how 340B is used to create subsidies for them and then defended because the places that are getting those subsidies are potentially sympathetic, or they're doing some good things over here. But that's not the origin of the 340B program. It was not designed to be a subsidy. And we heard earlier this afternoon, right? Some of the health centers actually still do operate that way, right? But the major hospitals that are getting most of the revenues through 340B are not operating that way. Today, 340B is not minimizing losses in the majority of cases. It's generating windfalls. It's a hidden subsidy that mostly benefits the biggest hospitals, paid for by shadow taxes on drug manufacturing and on everyone who pays an insurance premium. And it was fascinating to hear earlier people acknowledge this fact, right? Somebody comes in and they can't pay, then, or they're uninsured, then the 340B savings are passed on to the patients. But it's just assumed that if somebody shows up and they have insurance or they're covered by some third-party payer, well, we're going to charge them to the max, right? We're going to get that full spread pricing over the 340B wholesale discount. And then people turn around and wonder why health insurance premiums have gone up. I mean, it's fascinating to me as somebody who actually has to pay for health insurance that people don't seem to connect those dots. And while funds are, of course, fungible, which is to say that anyone who claims that their 340B revenues are going to this program is really sort of playing games, right? The research that I've conducted on 340B in all around the country has shown that, providers in places like New York City and Philadelphia, they say, well, you got to support our 340B program because we're using it for sex changes. We're using it to provide care for, undocumented workers, right? 340B in places where woke medicine is popular is claimed to be a great subsidy for woke medicine. In other places, it's claimed to go to other things, but 340B revenues just flow into the bottom line, right? There's no actual connection between 340 revenues and some particular program. It could be easily be said that they go to executive salaries at big hospitals, right? They'll never come before the legislature and say that, right? But it's as justifiable as any other claim. State legislators are asked to support all of this in exchange for much smaller revenue benefits for rural providers. Thankfully, the Trump administration is not such a cheap date. Neither it appears is Congress. The administration is pushing forward with important 340B reforms, while Congress is investigating and working on its own reforms. Ultimately, what we're talking about is a federal law augmented with federal regulations. State lawmakers should not signal support for a broken federal program and certainly not act to limit transparency and accountability within 340B. The first rule of medicine is supposed to be do no harm, and it's a good rule for public policy. Embracing 340B in its current form, even in a limited way, is a mistake. If rural health facilities and independent pharmacies need help, then help them. But supporting them need not and should not come at the cost of entrenching a broken, swollen, and misused federal program. Thank you, and I'm glad to take any questions. Thank you.
If you will. Lost my notes. Don Randall, Gas. And while she's coming, ladies and gentlemen, as our last of the day, I want to thank Dr. Sumner for her hospitality in a phenomenal facility here at the medical school. And thank you for getting us more doctors, because God, we need them in Georgia, since we're moving from the 8th most populated state to number 5 in a New York minute. Want to thank also for our lunch for the committee. And as she's coming again, for those of you that came and spent your day with us, it is a lot of information. Most of you are drinking like from a fire hose like we are. And again, thank you for your attendance, and you have the floor.
Thank you. Good afternoon to the chairman and members of the committee. Thank you so much for letting me have an opportunity to speak today. I spent my Don Randall Gaston, as he said, I spent my whole career, 40 years as a practicing pharmacy at DC General, Howard University Hospital, and People's Drugstore in DC. Then I came here to Georgia. I've been CVS, Kroger, Walgreens, Bibb County Health Department, where I started a clinic for the HIV, a pharmacy for the HIV clinic. And also has been a staff pharmacist at small family independence pharmacies here in Macon, FQHC. And my last assignment was a COVID investigator and health educator for the state. Across my 40-year career, I've worked in major chain pharmacies. I've worked the counter for just 2 independent shops and everything in between. I've seen firsthand the strengths and weaknesses of the different pharmacy types being debated today, but they all serve patients best they can, I believe. And it's important that pharmacists can keep their doors open and continue helping patients. I'm not here today to debate the merits of one model over the other, or to say one kind of pharmacy is best. I'm here because I spent 4 decades in this industry and know what happens to patients when a pharmacy closes. And I'm worried about what pharmacy closures of any kind could do to communities like Macon and other rural areas. And these potential closures would only make a bad situation worse. As one of my colleagues already stated, in rural Georgia, 6 counties have 0 pharmacies, and 42 of Georgia's 159 counties have no chain pharmacy at all. There's little room left to absorb further losses. Legislative efforts modeled on Arkansas's Act 624 or Tennessee's Fair Rx Act would put hundreds of Georgians' pharmacies, which serves millions of patients, at risk of closure. Millions of Georgians have no comparable nearby alternatives either. Looking at Ohio, this may not be our alternative, but just looking at one that may work. Ohio recently passed House Bill 229, which takes effect next July. This law creates mandatory licensing for PBMs, improves PBM price transparency, and increases protections and avenues for remedying concerns for both pharmacies and consumers. Importantly, this law is not expected to reduce access to prescriptions or pharmacies in any way. Now, I'll be transparent and be honest. Much of the frustration driving this issue is legitimate. But Georgia should address these frustrations directly and avoid making more problems in the process. The Tennessee approach threatens to reduce access without addressing the underlying reasons independent pharmacies are struggling. Georgia should instead pursue thoughtful, targeted reforms that fix the real problems without threatening reduced access to rural Georgians, senior citizens, and other folks who rely on mail order and specialty pharmacy services. In closing, I've spent my career on both sides of this debate, in big box pharmacies and independent ones, FQACs, and I can tell you, access doesn't care which model fills a prescription. It only cares whether the pharmacy is open. I only ask that this committee get the diagnosis right before reaching for the treatment. Georgia doesn't need a law that closes more pharmacies. It needs one that keeps the doors open, that maximizes health equity, enhances it diminishes the occurrence of pharmacy deserts, enhances compliance, and help us as pharmacists continue to do our work. That's all we ask. Thank you.
Thank you, Dawn. Questions? Appreciate you coming to present, and you were dead on everything. So we appreciate you very much.
Thank you.
Ladies and gentlemen, our next meeting, we hope, is a target of around October the 1st or 2nd. We expect this is going to sound odd, a transparent PBM to come and present to our committee as we wipe things up. And this has been an enormous amount of information. NADAC has saved an enormous amount of money to the taxpayers. We'll talk about that a little bit more. But I especially want to thank you guys that took your day out to come and learn with us, if you will. And we'll keep you informed of when and where our next meeting will be. I would suggest if you come that you bring your appetite for seafood. We have some good places down there. Thank you so much, and we're adjourned.